Hello, everyone. In the last lecture, we have discussed general pathology. We have discussed cellular adaptation. We have discussed how a change in stress or increase and decrease in stress can change the cell size or number, or its all composition. Like we have discussed the hypertrophy case. We have discussed the hyperplasia case. Hypertrophy is increase in size. Hyperplasia increase in number. We have discussed how a hyperplasia can progress to the cancer. But there is one example, which is BPS, and that can never progress to the cancer. How the atrophy happen, that the decrease in cell size as well as in the number. Then the change in stress completely can change the cell type, and this is known as the metaplasia, which is the reprogramming of the stem cells. You need to remember only the cells which has stem cells can undergo the metaplasia. Okay, that means the permanent cells can never undergo metaplasia. Okay, we have discussed the examples. We have discussed the GERD syndrome. We have discussed cigarette smoking. We have discussed how this uh, vitamin A deficiency can lead to keratitis, and the apocrine metaplasia. We have discussed this apocrine metaplasia can never progress to the cancer, while all other type of metaplasias ultimately can progress to the cancers, right? We have discussed the dysplasia with a disordered growth. It is not a normal thing. We have discussed the difference between the dysplasia and the cancer. We have discussed that dysplasia is kind of reversible, okay, and why the cancer is irreversible. But ultimately, both things are quite same. Ultimately, if the stress is persistent and not decreased or removed, then this the dysplasia progress to the cancer ultimately, right? We have discussed where the stem cells of different organs lies. In the GIT, it is the intestinal crypt cells. In the bone marrow, it is the hematopoietic cells. In the gonads, it is a spermatogonia. In the skin, it is a basal layer. And for the hair, it is a hair follicle. Then we have discussed how the cell injury happened. What is the hallmark feature of this reversible injury, which is the cellular swelling. Okay, ultimately cell swelling, ribosomal swelling, cell swelling, rough endoplasmic reticulum swelling, and the mitochondrial swelling. These three things happens, right? In case of irreversible injury, there is a cell damage, a complete membrane damage will occur, right? And as a result, the different enzymes which are present in the cell, they will leak out. And we have discussed how this myocardial infarction leads to increase in the troponin level and the CKMB level. It is because of the membrane of the cell which get damaged, which get broken down, and as a result, all these enzymes will be leaking out. We have discussed how this lactate dehydrogenase is the marker of cellular injury because it is present in every cell, right? And ultimately, if the cell membrane damaged, this enzyme will be leak out, and as a result, you will have this high level of this enzyme, right? And we have discussed some examples of it. Then we have moved forward and we have discussed how the cell injuries can happen, the two ways by which the cell can die. One is the apoptosis and second is the necrosis. In the apoptosis, we have discussed this DNA laddering phenomena and what are the changes you will see in the microscopy. We have discussed the cellular shrinkage thing. Okay, we have discussed the two pathways for the apoptosis. One is the intrinsic pathway and second is the extrinsic pathway. We have discussed how this intrinsic pathway works and its examples. We have discussed about this P53. You know, if this mild mutations happen in your cell, then what's going to happen? The P53 will call for the DNA repairing enzymes. Okay, and if the DNA damage is too much, then ultimately this P53 will activate the backs and back, and they will form pore in the mitochondria. The cytochrome C will leak out and causing the apoptosis. We have discussed the follicular lymphoma case, how this, the change in the genes, the translocation of genes can lead to the very high production of BCL2, and as a result, the cell will become very stable, and won't undergo the apoptosis because of this BCL2, right? Then we have discussed the extrinsic pathway. We have discussed their examples, which is the fast leak and fast receptor that happens in your thymus gland and during the negative selection. We have discussed about this TNF alpha and its receptor thing. We have discussed how this cytotoxic T cells lead to the apoptosis of the tumor cells or the viral infective cells, which is by the granzymes and the perforins. We have discussed if the fast leak and fast receptor pathway become mutated, then it will lead to the autoimmune lymphoproliferative syndrome, in which you get the autoimmune disorders and the lymphoma risk. We have discussed how this internal ribosome entry thing works. without this intrinsic factors or without this 5-methyl guanosine cap or the Kozak sequence. Then we are moving forward and we have discussed about this necrosis, the types of necrosis. We have discussed that necrosis is always pathological, and whenever there is a necrosis, there is always going to be the inflammation. We have discussed the hallmark of the inflammation, which is the giant cells. In every inflammation, you will see the giant cells, okay? But in the granuloma, the hallmark feature is the epithelioid cells, okay? You will see epithelioid cells only in the granuloma. Okay, we have discussed the 6 type of necrosis, the cognitive, which is most common, and whenever a blood supply to certain organ is lost, it's always going to be a case of cognitive necrosis, except the brain. For the brain, if the blood supply is lost, if the stroke happen in the brain, it will lead to the liquefactive necrosis. Okay, we have discussed why this liquefactive necrosis is happening, because of the neutrophils. The neutrophils will reach there, they will release their hydrolytic enzymes, the lysosomal enzymes, and that will lead to the tissue degradation. We have discussed the caseous necrosis, which happen only in case of granuloma, like TB, like systemic fungi, like dysnocardia. We have discussed the fat necrosis, which happens only in the fatty tissues, which is the fatty tissue around this pancreas and your breast. Okay, and we have discussed how this saponification will occur in case of a fat necrosis because of the calcium deposition. We have discussed this histological feature with saponification, which is this bluish thing you're seeing in the histology. This is the calcium deposits in the fat, and all of this is the fat necrosis. We have discussed the fibrinoid necrosis and the 3 cases in which you get the fibrinoid necrosis. One is the polyarteritis nodosa, very hallmark feature. Second is the hypertensive emergency. We have discussed in case of hypertensive emergency, you will get a blood pressure of greater than 180, and and a sign of organ damage. And this organ damage can include anything like a blurring of vision, or the liver pain, or the flank pain, or could be anything. Okay, so a high BP with any kind of symptom is the hypertensive emergency. And we have discussed the case of preeclampsia. Okay, vasospasms going to happen in the preeclampsia as well as a fibrinoid necrosis. We have discussed why the fibrinoid necrosis is happening, because of the plasma proteins leakage, and and they will settle in the blood vessels. Okay, we have discussed this gangrenous necrosis. Okay, and we have discussed the 2 types, the dry gangrene and the wet gangrene. The dry gangrene happens when only single blood supply is present, and sudden loss of blood supply leads to the loss of everything, every cell. Not even the bacteria can survive in these conditions, and as a result you will get the dry necrosis, this dry gangrene. We have discussed the wet gangrene, in which an organ is supplied by 2 blood vessels. If it become infarct, then 1 blood vessel is still be supplying that organ, and as a result the bacteria can grow at this place, and that can lead to the wet gangrenous necrosis. Okay, and now we're going to discuss how the ischemia happen, which are the organs which are most commonly affected by the ischemia. Okay, and you need to know that ischemia can happen due to 2 things. One is a decrease in the atrial perfusion, and second is the decrease in the venous drainage. You need to know not only the atrial perfusion, but even if the venous drainage is blocked, then you will get the ischemia also. Okay, so the example for the decrease in atrial perfusion can include the atherosclerosis, which is a formation of a lipid plaque inside the blood vessels. Okay, or it could be the hypertrophy of the blood vessels, right? And the venous drainage, you need to know in the case of testicular torsion, for the testes you have these 2 blood vessels, the arteries and the veins. And if the torsion happens, because the veins are very thin walled, and they will block first, and as a result the venous blockage happen first in case of testicular torsion. Okay, then we have this, and then you need to know about this Budd-Chiari syndrome, in which the liver vein, the vein which is draining the blood from the liver, get blocked, and you will get the Budd-Chiari syndrome. So not only the atrial perfusion, but also the venous drainage can lead to the ischemia. So what are the the watershed areas in case of different organs? In case of a brain, this would be the boundary areas between the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. Let me draw this for you. Let us suppose this is your brain. Okay, and the temporal side is supplied by the middle cerebral artery. The posterior side is supplied by the this PCA, and this anterior side is supplied by the ACA, and the watershed zone between them is like that. Okay, you will get these strips of the watershed zone in case of any blockage like that. So this is a watershed zone between these arteries. Okay, and this would be the area that will become first damaged whenever a blood supply to the brain is lost. Okay, and I'm talking about the diffuse supply. Okay, then comes the heart, the endocardium, which is the innermost, sorry, the subendocardium. Okay, which is the innermost layer of the heart. It is get a damage first in case of any infarction happen to the heart. Okay, because your endocardium is directly supplied by the blood in the ventricles. Okay, so endocardium won't be damaged in case of ischemia. Okay, the subendocardium, which is just above the endocardium, it would get damaged first. Okay, because it is totally dependent upon the cardiac vessels to supply blood, right? Then comes the kidney. In the kidney, it is the PCT. Okay, and the thick ascending loop. Very important to know the PCT and the thick ascending loop, because these are the areas which are a kind of highest working area in the kidney, right? So they require oxygen too much than any other areas in the kidney, and that's why they will damage first in case of ischemia. Then in the liver, it will be the zone 3, which is the innermost zone, just around the central vein. Let me draw this for you again. This is your hepatic lobule. It's kind of a hexagonal structure. In the central, there is a central vein. Surrounding the central zone, the central vein is a central zone. Then comes the middle zone, and then comes the peripheral zone. And there is a portal right present, right? So the arterial blood and the portal venous blood will be present here. Okay, and the blood will go from here to here. So this innermost area, which is a zone 3, this is the watershed zone in case of liver. Okay, in case of colon, this would be the rectosigmoid junction and the splenic flexure. Very important, no? The splenic flexure and the rectosigmoid junction would be the watershed zone in case of colons. Okay, let me again draw this for you. If this is your colon, this is a splenic flexure, which is supplied by the which arteries? Anyone can tell me which artery supplied this zone? Two arteries.
Superior mesenteric artery and inferior mesenteric artery.
So yeah, exactly. So the zone between the superior mesenteric artery and the inferior mesenteric artery, which is a splenic flexure, it is the watershed zone, and this is the rectosigmoid junction, which is totally supplied by the inferior mesenteric artery. Okay, but different branches of the inferior mesenteric artery supplies here, and this is the watershed zone. Very important to know. Okay, then yeah, and you need to know the highest oxygen requiring areas in the brain, which is the Purkinje cells of the cerebellum and the pyramidal cells of the hippocampus, and the neocortex, which is the zone 3, 5, and 6. These are the areas which are most vulnerable to the hypoxia. Okay, because they require oxygen too much. So these are the watershed areas. Okay, that damage will happens in case of ischemia. Okay, and let us suppose you lost the glucose in the blood. Okay, and the glucose is required for the energy production. So in case of hypoglycemia, these organs will be damaged first. These areas of the brain will be damaged first. Okay, because they require the highest amount of oxygen and highest amount of energy for function. Okay, so not only in the arterial perfusion, but if the glucose of the body is lost, the hypoglycemia occur, then these area will damage first because they require highest oxygen. Okay, do not confuse between the watershed zones and these cells or areas, right? Then the type of infarcts we need to discuss, and these are the red infarct and the pale infarct. Okay, and you need to know the most common infarct is the pale infarct, which occurs in those organs which are supplied only by one arteries. Okay, that means the end organs. Okay, for example, your heart, your kidney, and as you can see, if the blood supply is lost, the redness of the area is lost, and you will get this pale region. Okay, so this is the pale infarction. Okay, and then comes the red infarct. It is happening only on those areas which are supplied by multiple arteries and very loose areas. Okay, okay, so those areas which are supplied by multiple blood vessels. For example, your liver, which is supplied by which is supplied by one artery and one vein, which is the hepatic artery and portal vein. So multiple blood supply. The lungs supplied by two arteries, which is one is the vein and one is the direct those bronchial arteries. Okay, then testes and intestine. All of them are supplied by multiple blood vessels, and that's why in case of the infarction occurs, then other blood supply would be there to for let me show you this. Let us suppose this is your lung, okay, and it is supplied by two arteries. One is the vein, the pulmonary vein, and second is the bronchial vessels. So in case of an infarction happens, then what gonna happen? Let us suppose this area will die, and these will ultimately join to form the. Let me show you this. Okay, so this is the structure of your a kind of simplistic a diagram of the supply of the lung, right? And this is the bronchial veins. Sorry, and the bronchial arteries, and these are the pulmonary veins. Ultimately, they will join to form the pulmonary artery, right? So if a blockage happen in that area, then this area will still be supplying the structures, okay, and no infarction will occur. If this area get damaged, then the pulmonary veins will be supplying the structures and no infarction will happen. But if this area is damaged, if the pulmonary artery is lost, then ultimately this area and this area, they, you know, they cannot supply these structures anymore, and as a result you will get the infarction, and in this case you will get the red infarction because of lots of blood in this area. Okay, so very important to know, because they have just multiple blood supply, they are a very less vulnerable for the whose speaker is this. Let me check just a second. Okay, so in case of a blockage of the artery, okay, you won't get the infarction. In case of a blockage of the pulmonary vein, in case of lung, you won't get the infarction. But in case of a blockage of the pulmonary artery, you will get the red infarction. Okay, because it is supplied by the multiple vessels. This area and this area both will be supplying the lung, and as a result, the blood would be there, inside the lung in case of infarction, and you will get the red infarct. Very much important to know. Okay, because this area is supplied by the multiple blood vessels, that means it is least vulnerable to the infarction. But infarction will only occurs if this pulmonary artery will be damaged. Okay, similarly in case of a liver, if the if this portal vein thrombosis occur, you won't get the infarction in the liver, right? And if the hepatic atherosclerosis occur, you won't get the infarction in the liver. But in case of a blockage of the vein, which is the hepatic vein, you will get the Budd-Chiari syndrome, you will get the liver infarction, because it would be the vein which is draining the blood from the liver ultimately, right? So very much important to know this concept. Then we will discuss about the free radicals injury. Okay, and for the free radical injury, let me just open my file. I have a simplified way to learn it. Just hold on a second. Okay, so this is a free radical damage that we're going to study now. Okay, so for the free radical damage, you need to know the reactive oxygen species, which are the free radical of the oxygen, okay, and the hydrogen peroxide, okay. And what these oxygen free radicals gonna do? They will cause the oxygenations of the different structures inside the cell. For example, the cell membrane, the DNA, the proteins, the organelles which are present in the inside the cell, and they will oxidize them. Okay, and that's how they causes the damage. Okay, and then you need to know how the free radicals can be formed. They can be formed by the inflammation, like we have discussed. The respiratory burst. We have discussed the radiation. They can cause a free radical damage. Certain drugs, for example, the acetaminophen that you use, they can cause a free radical damage, and that's how you get the liver infarction in case of acetaminophen overdose. Okay, certain metals like iron, like copper, they can cause a free radical damage formation. Nitric oxide, they can cause the free radical formation. Okay, how the damage gonna happen? The outermost structure of the cell is the lipid membrane. Okay, so they will cause the lipid membrane peroxidation. Okay, then inside the cell there presents the proteins. They will cause the oxidation or the modification of the proteins inside the cell. Okay, and the innermost inside the cell, it is the DNA, and they will cause the DNA damage due to the free radicals. So three things gonna happen when the reactive oxygen species form. First is the membrane lipid peroxidation, which is the outermost layer of the cell. Then the proteins inside the cell, they will be modified or the oxidized. Okay, and third is the DNA damaged by the free radicals. So let's talk about some examples. In case of a oxidative burst or the respiratory burst, what's going to happen? The oxygen will be converted into the oxygen free radicals, then to the hydrogen peroxide, and then to the hyperchloride by the action of enzymes NADPH oxidase, the superoxide dismutase, and the myeloperoxidase respectively. As you guys know, we have discussed this thing, right? And once these reactive oxygen species form, and they will cause these damages that we have studied here, right? The membrane lipid peroxidation, the oxidation of the proteins, and the DNA damages. Okay, and you need to know what kind of proteins or what kind of substances are kind of very protective against this reactive oxygen species. And these are the glutathione, very much important. We have discussed the function of glutathione. It would convert the H2O2 into the water itself. Okay, so glutathione is kind of very protective. Okay, the vitamin A, C, E, we have discussed that these are the antioxidant vitamins, and that's why in case of a vitamin E, you are getting the hemolysis because of the oxygenation inside the RBCs, right? Then comes the radiation. Radiation most commonly damage your DNA. Okay, and they will cause the free radical oxidation of the DNA and the double-stranded breaks inside the DNA. Okay, we have discussed the one disease in the immunology. Can anyone remember the name in which you will become very sensitive to the radiation?
Ataxia telangiectasia.
Exactly. Why? Because the radiation causes a double-stranded DNA breaks, and as a result, you need the DNA repairing enzymes. But in case of ataxia telangiectasia, you do not have the DNA repairing enzymes, and you will get the DNA damage, and again the free radical oxidation. Then comes the drug, and the drug we need to know about is the acetaminophen, which causes the liver damage by generating the free radicals, free oxygen radicals. Okay, you need to know that this acetaminophen will be converted to its, the activated form or the toxic form by the cytochrome P450. Okay, and that means, and therefore the in case of a chronic alcoholism, as we already know that in case of a chronic alcoholism, you will have this activated form of cytochrome P450 too much, right? So in case of an alcoholic, if you give the acetaminophen even a little bit, it can cause a very large DNA damage. Sorry, and the large liver damage. Why? Because it is activated by the cytochrome P450 into its toxic form. And in case of a chronic alcoholism, this alcoholism can increase the values of this cytochrome P450. Okay. And how you can treat a toxicity? By giving the patient N-acetylcysteine, okay, which is a kind of antioxidant. Okay, very much important to know. And then step one can also ask you the name of the substance which causes the DNA damage, the name of this active metabolite. Okay, and this name is N-acetyl P benzoquinone. Okay, N-acetyl P benzoquinone, which is the activated form or the toxic metabolite of the acetaminophen. Okay, which causes this liver damage, and this could be neutralized by the N-acetylcysteine or the glutathione itself. Okay, by the N-acetylcysteine mainly, right? So you require the N-acetylcysteine for the treatment of this, the acetaminophen toxicity, very much important to know. And in case of alcoholics, because the cytochrome P450 levels are already very much raised in the chronic alcoholism, so if they take even you know uh, a slight values of this acetaminophen, and they will be readily converted into the activated form, the toxic form, and they can cause the liver damage. So very much important facts to know. Then comes the metals like iron and the copper. They can cause a free radical oxidation and the damage to a certain organs. For example, in case of a Wilson's disease, you will get the liver damage, right? And you will get the brain damage in case of a Wilson's disease. In case of a hemochromatosis, which is iron overload, you will get the liver damage, right? So these these metals can also cause a free radical oxidation. Okay, and then you need to know certain protective mechanisms also exist inside our body to protect that the damage from these elements. And for example, the transferrin, which carries the iron, and the cycloplasmin, which carries the copper, they are kind of very much protective from these metals. Okay, then direct oxidative injury can also happen. Okay, for example, in case of a neonatal respiratory distress syndrome, okay, you will give them the 100% oxygen, and this 100% oxygen can lead to the retinopathy or the reperfusion in, it could cause a retinopathy. Okay, and the second example includes a reperfusion injury. Whenever a blood supply to a certain organ or certain a muscle is lost, you know, and then you kind of reperfuse that area. So instead of improving the conditions of that area, you will see the rise in the markers of certain enzymes. You know, it would cause even more damage to that area. And this is why and why this happened, because of the reperfusion injury, because of the direct oxidative injury. Okay, when you open the blood supply to certain areas, the reactive oxygen species form, and they will cause the damage even more. Okay, so step one can ask you the question on this. Okay, and they will give you a scenario for myocardial infarction, and they will and tell you the patient was undergone the kind of this reperfusion, and after reperfusion the patient had this reperfusion injury. The patient started having this rise in the cardiac marker like troponin and CKMB or the LDH, and they will ask you why the rise in these markers are happening, and this is because of the free radical oxygen generation inside the cells, right? And as a result, the cell membrane will be peroxidized, it would be damaged, and as a result all these enzymes will be leaking out of the cell, causing the rise in their levels. So very much important to know the reperfusion injury which occurred due to direct oxidative injury. Okay, the neonatal respiratory distress syndrome that can lead to the retinopathy of the prematurity is an example of direct oxidative injury. Then comes the carbon tetrachloride, which is converted to its activated form, the carbon trichloride, by the cytochrome P450. Okay, and this causes the free radical oxidations of different proteins, cell membrane, and the DNA. And as a result, because the proteins are damaged, you cannot pack your cell inside these proteins, and as a result these the proteins the fat will be start accumulating inside the liver, causing the fatty liver, because you require the lipoprotein synthesis for the transfer of fat. But in case of a carbon tetrachloride, the proteins will be denatured by the peroxidations, and as a result the fat will be start accumulating inside the liver, causing the fatty liver. So they can ask you the question of this carbon tetrachloride, that what you could expect on the histology of the patient. This would be the fatty liver. They can ask you why the fatty liver is happening in case of a carbon tetrachloride, and because of this inhibition of the lipoprotein synthesis. Okay, they can ask you about the activated form, which is a carbon tetrachloride. Okay, and so yeah, that's all FA tells you about this free radical oxidation. Okay, the free radical damage cells by the membrane lipid peroxidation, by the protein modification, which is the oxidation of proteins, and the DNA breakage. Okay, the radiation exposure, the metabolism of certain drugs, the redox reactions which happen in case of a metals. Okay, nitric oxides, the transition metals, WBCs. I've told you about the inflammation, the respiratory burst. All of they can generate the reactive oxygen species, and this reactive oxygen species can cause damage to a cell by three ways, which is the membrane lipid peroxidation, the protein modification, and the DNA breakage. Okay, we have discussed the protective mechanism, which are the catalase, the superoxide dismutase, and the glutathione peroxidase. You need to remember the enzymes name. These three enzymes, the catalase, the superoxide dismutase, and the glutathione peroxidase. These are the protective enzymes from the reactive oxygen species. And then the antioxidants, which are the vitamin A, vitamin C, and vitamin E. And we have discussed the carrier proteins of certain metals, which are the transferrin and the celloplasmin. They all are kind of very much protective against the reactive oxygen species. We have discussed some example, the direct oxygen toxicity, which is happen in case of a retinopathy of the prematurity, and the reperfusion injury that happens after a thrombolytic therapy. For example, in case of a myocardial infarction, we have discussed, instead of getting symptoms improved, you will get the worsening of the symptoms because of the reperfusion injury. The generation of the reactive oxygen species happens because of the direct oxygen toxicity. Then we have discussed certain chemicals, the carbon tetrachloride, which could be converted into activated form by the cytochrome P450 and causes the fatty liver syndrome. Then the metal storage diseases, in case of a hemochromatosis, you will have this iron overload. In case of a Wilson's disease, you will have the copper overload. And both of these metals by the Fenton reaction can cause the free radical oxygen formation, and that can cause the certain organ damages. Okay, we have discussed the active metabolite of the acetaminophen, which is the N-acetyl P-benzoquinone. Okay, this should be converted into the detoxic form, and which is done by the glutathione or the N-acetylcysteine. Okay, N-acetylcysteine ultimately forms the glutathione, which is very much protective against this metabolite. Okay, so any doubt in the free radical oxidation? Any doubt in free radical oxidation?
No. No.
Okay. Then you need to know the different type of calcifications. One is a dystrophic calcification, and second is the metastatic calcification. Dystrophic calcification occur in the damaged tissues. Okay, whenever a tissue is undergone any kind of a necrosis or any kind of a damage, then the dystrophic calcification occurs. The calcium will start depositing on this tissue, causing the calcified tissue. And as you can see in the histology, this is what the calcium look like in the H&D staining, the bluish, okay, bluish purplish or violet. Okay, for example, in case of aortic stenosis, you will have this chronic aortic valve this damage, and as a result, this aortic valve will be calcified, causing the calcification in the aortic stenosis. In case of a TB, you will get this granuloma, and as a result of the granuloma, you will get this calcification because of the damage caused by the granuloma. Okay. In case of a liquefative necrosis in the brain, you will get the calcification ultimately. Okay, in case of abscess, similarly, in case of fat necrosis, because cells are undergoing the necrosis, you will get a deposition of fat. Okay, in case of a thrombi formation, in case of atherosclerosis formation, remember the atherosclerosis, it would be ultimately, covered by the calcium. Okay, very much important to know. The samoma bodies that in case of a tumors, these are all due to the calcium deposits. The calcium deposit in case of a concentric layers, in case of samoma bodies. Okay, the atherosclerotic plaque ultimately will be calcified, right? The crest syndrome that these are all example of the dystrophic calcification. The dystrophic calcification only occurs when a cell damage or a tissue damage occurs, right? But in case of a metastatic calcification, the calcification happening because of a too much calcium level inside the blood, because of the hypercalcemia. So in case of a metastatic calcification, first you will get the symptoms of the hypercalcemia. Okay, and the symptoms could be the polyuria, the polydipsia. Okay, very much important. And this polyuria, polydipsia will occur. Why? Because of the calcification of the collecting ducts. Okay, because of the calcification of the collecting ducts, you will get the polyuria and polydipsia. You will get a diabetes insipidus. Very much important to know. In case of a high calcium levels, in case of a hypercalcemia, you will get the calcification of the collecting ducts that can lead to the nephrogenic diabetes insipidus. And as a result, you will get the polyuria and polydipsia. This is the first symptom in case of hypercalcemia. Very much important to know. Okay, and then you will again get the widespread deposition of calcium. You will get the calcium deposition in the arteries. Okay, very much important. You will get in the other like lungs, in the gastric mucosa also. Okay, so what are the causes of the hypercalcemia? It could be the hyperparathyroidism. Okay, it could be the sarcoidosis. Okay, it could be the hypervitaminosis D. If you get too much of the vitamin D, it can lead to the hypercalcemia, because we know that the vitamin D will lead to the increased reabsorption of calcium in the PCT, and also the increased absorption of the calcium in the GI tract. So hypervitaminosis D, hyperparathyroidism, sarcoidosis, these are the examples of the hypercalcemia. Okay, you can get the chronic kidney disease. In case of a chronic kidney disease, with the kidney failure, you will get the high calcium levels, and these high calcium level will be start depositing inside the arteries mainly, causing the calcified arteries. Okay, the multiple myeloma is an example, is another example. Okay, so signs and symptoms of hypercalcemia would be present in case of a metastatic calcification, and in case of a dystrophic calcification, you will only get the deposit of calcium in the damaged tissues. Okay, so any doubt in the type of calcifications? Anyone, any doubt?
No.
Okay, then you need to know about a pigment which is a lipofuscin. Okay, lipofuscin is a wear and a tear pigment that occurs with the aging. Okay, the lipid peroxidations of the membrane will lead to the formation of this pigment. Very much important. It is because of the membrane lipid peroxidations. The step one will ask you the question over it, why this lipofuscin is forming inside the cell, and why it is forming because of the membrane lipid peroxidation. You need because you already know that with the aging, you know along with the aging, you will have the damage from the certain reactive oxygen species, and this reactive oxygen species can cause the membrane lipid peroxidations. And after this membrane lipid peroxidation, you will get the formation of the lipofuscin. Okay, so whenever you would do autopsy of a old age patient, you will always see this brownish kind of pigment inside the cells, and this is the lipofuscin. Okay, it will deposit inside the heart. It could deposit inside the colon, inside the liver, inside the kidney. So whenever a step one will give you autopsy of a patient, of an old age patient, and they will tell you that in the histology you will be seeing these kind of pigments inside the cells, this means they were talking about the lipofuscin. Okay, you need to know that the iron deposits inside the cell and the lipofuscin both could be seen in the HND staining as this brownish pigments. Okay, so how you can differentiate between the iron deposits and the lipofuscin? This would be the Persian blue staining. In case of a Persian blue staining, you will have the iron to be turned into blue. Okay, but the lipofuscin will remain brown in only, right? So it would be a yellowish brown, finely granular intracytoplasmic pigments. And why? Because of the lipid peroxidation happens only in the old age patient. So if the autopsy of a young age patient is given, then it can never be the lipofuscin. It either could be the melanoma, or it could be the iron deposition. But in case of old age patients, most commonly it could be the lipofuscin. Okay, and the most common locations include your heart, colon, liver, kidney, and eye. Okay, any doubt on the lipofuscin? Anyone, any doubt?
No, sir. No.
Okay, then you need to know about the amyloidosis. So any protein inside your body, okay, which is converted into the beta plated structure. Okay, and ultimately this beta plated structure is non-degradable inside the body, right? It can form the amyloid protein. So amyloid is basically any kind of protein which is become into the beta plated structure, and this beta plated structure is indegradable. Okay, this is termed as the amyloidosis. Now what happens is, ultimately when the proteins become into this beta plated structures and they become indegradable, they will start depositing outside the cells and inside the tissues, right? And ultimately causing the tissue damage. Okay, and that's where you get the symptoms in the amyloidosis. So amyloid is basically any kind of protein which is now become indegradable. Okay, and every amyloid protein has this beta plated sheet structure. Okay. Step 1 will ask you how you can identify the amyloidosis. It could be done by the Congo red staining. Okay, in the Congo red staining, you will have this reddish deposits. And one of the most important location of this amyloid deposits are around the blood vessels. So in the center here in this diagram, in this histology, you will see these blood vessels, and around the blood vessels, these are the amyloid. Okay, and amyloid is any kind of protein which is now become indegradable because of a beta plated sheet structure. Okay, so the amyloid will be always seen around the blood vessels. Okay, and outside the cell. Okay, amyloid cannot be intracellular, it must be the extracellular only. Okay, second is the apple green bifringence. In case of apple green bifringence, you will see this greenish deposits. These are the apple green bifringence. You can also do the H&D staining, and in case of H&D staining, you will see the homogeneous pink amorphous substance extracellularly. Homogeneous pink amorphous substance homogeneously in case of a H&D staining. Okay, so these are the three ways which you can detect the amyloids. Okay, and generally the amyloid always a deposit around the blood vessels. Very much important to know. Okay, all amyloids have the beta plated sheet configurations, and all of them are resistant to the degradation. The three ways to analyze them: one is the H&D staining, second is the Congo red staining, and third is the apple green bifringence. Then two type of amyloids exist: one is the systemic, and second is the localized. Okay, for the systemic amyloidosis, you will have the deposition of the amyloidosis in multiple organs. That means systemic ultimately. Okay, so one is the primary amyloidosis, and that happens because of a deposition of the light chain, immunoglobulin light chain. You guys remember the immunoglobulins have two chains, one is the heavy chain and one is the light chain. Okay, and if the light chain is forming too much inside the body and converting into the beta plated structure, they will become indegradable and hence started depositing inside the tissues, inside the organs, causing the amyloidosis. So primary amyloidosis is because of this Ig light chain, and it is seen in the plasma cell disorders. For example, the multiple myeloma. In case of a multiple myeloma, because it is a plasma cell disorder, you will get a plasma cell tumor, and these plasma cells will form too much of the antibodies, too much of the light cells, light chains, and as a result, these light chains will start depositing inside the different organs. For example, in case of a heart, it will form the restrictive cardiomyopathy. In case of a GI, you will see this hepatomegaly. In case of a kidney, you will have this nephrotic syndrome. Most important thing to know, the this amyloidosis will cause the nephrotic syndrome in the kidney. Okay, you will get the easy bruising and the splenomegaly. Why easy bruising? Because like I told you, the amyloid will always deposit around the blood vessels, making the blood vessels very damaged, very leaky, and as a result you will get the easy bruising in case of amyloidosis. Okay, then in case of a brain, you will get the neuropathy. Okay, in case of a MSK areas, you will get the carpal tunnel syndrome. Very important to know. In case of a bones, in case of the musculoskeletal areas, you will get the carpal tunnel syndrome. So amyloidosis is one of the important cause of the carpal tunnel syndrome. Okay, you will get the impingement of the median nerve. Okay, second is the secondary amyloidosis. Okay, in case of a secondary amyloidosis, there is an acute phase reactant, which is a serum amyloid A. Now, this acute phase reactant always increase in the number whenever an infection happens in your body, whenever an inflammation happens in your body, and that's why it is an acute phase reactant, right? But if the inflammation is persisted for too much period of the time, for example, the chronic inflammatory disorders like the rheumatoid arthritis, like the inflammatory bowel disease, or the familial Mediterranean fever. Okay, so any kind of a chronic infection, even a cancer, that can lead to a deposition of this serum amyloid A. Too much formation of the serum amyloid A will happen, and it starting depositing inside the tissues, outside the cells, causing the secondary amyloidosis. And similar symptoms will occur. It will deposit inside the heart, it will deposit inside the GI tract, it will deposit inside the kidney, the blood vessels, the brain, the musculoskeletal areas, and causing all these symptoms, right? The third will be your dialysis related amyloidosis. Remember the function of this beta 2 microglobulin? Anyone? Where
In
you find this
MHC1,
protein? Yeah,
MHC1.
exactly.
receptor,
Yeah, exactly. MHC1. It is
part
kind
of
of a
T cell.
yeah. Please repeat it again.
It's a part of T cell receptor.
No, not a part of T cell receptor, but MHC1. Remember the alpha chain and the beta chain? In case of MHC1, you will have this beta 2 microglobulin, which is kind of a supportive
Yeah.
protein in the MHC1, right? So in case of a dialysis, what happens is, in case of a artificial dialysis, this protein won't be filtered in the dialysis unit, and as a result, it will start depositing inside your body, converting into the beta plated structure, and become resistant to the degradation. Okay, starting depositing inside the tissues. Okay, so you will see the beta 2 microglobulin always in the end stage renal disease patients who are undergoing the long term dialysis, because in the dialysis, you won't filter the beta 2 microglobulin. So it will deposit inside the heart, the GI tract, the kidney, the blood vessels, the brain, and the muscles also. So the three examples for the systemic amyloidosis: why systemic? Because they're affecting multiple organ system inside the bodies, right? Now, second type are the localized amyloidosis. Why localized? Because they're affecting only one organ. Okay, like in case of Alzheimer's disease, you have this beta amyloid protein. Okay, and you need to know the precursor protein of this beta amyloid, which is the amyloid precursor protein. And the gene for this amyloid precursor protein is found on the chromosome number 21. And that's why in case of a Down syndrome, you have three genes instead of two for this amyloid precursor protein. Okay, so you're forming too much of the amyloid precursor protein in case of Down syndrome, right? And if you form too much of this amyloid precursor protein, it will be converted into the beta plated structure, which is a beta amyloid protein. Now it become indegradable. It will start depositing inside the brain, causing the Alzheimer's disease. And if the step one will ask you the location of the deposits of this amyloid inside the brain, it would be around the blood vessels, right? Very much important to know. Then comes the type 2 diabetes mellitus. In case of a type 2 diabetes mellitus, remember, in the initial stages, you will have the too much insulin production uh, uh, by this pancreatic beta cells, and ultimately the pancreatic beta cells will be exhausted, and you will get the low insulin levels. So during these high insulin levels, because the pancreatic beta cells are forming too much of the insulin, they will also form the amylin along with it. Okay, and this amylin will be converted into the islet amyloid peptide, IAPP, and this is the amyloid in the pancreas. So you will get the deposits of this islet amyloid polypeptide in the pancreas, causing the localized amyloidosis in case of type 2 diabetes mellitus. Okay, so whenever you do a histology or the biopsy of the pancreas of a type 2 diabetes mellitus patient, you can see these islet amyloid polypeptide deposits. Okay, either the HND stain, either the congruent stain, or the Appelkin bifringes. In case of a medullary thyroid carcinoma, okay, which is which is just a second. Okay, in case of this medullary thyroid carcinoma, you will get the formation of the calcitonin too much. Remember, the calcitonin is an hormone secreted by the thyroid glands. Okay, so in case of a medullary thyroid carcinoma, you will have too much formation of the calcitonin, and now this calcitonin would be converted into the beta plated sheet structure and forming the amyloid. Okay, then isolated atrial amyloid, which is a deposit of the ANP. Remember the function of ANP and BNP. Okay, so so in case of a normal aging ASO, you will have the deposits of the ANP causing the amyloidosis. Okay, then one is the senile amyloidosis, which is the age related. Okay, you will get a deposit of certain proteins like the transthyretin, okay, in the tissues inside the heart most commonly. Okay, and this is the senile amyloidosis, the deposition of the transthyretin. It is always occur in the aging, and that's why in the aging there is an increased risk of restricted cardiomyopathy, okay, in case of old age patients because of the deposition of this transthyretin. Okay, Then finally, the hereditary diseases. One is the familial amyloid cardiomyopathy. In this case, instead of this normal transthyretin, you are having the deposition of mutated transthyretin. Okay, and you will get the restricted cardiomyopathy because of the heart. Okay, and the last one is the familial amyloid polyneuropathies. In this case, also you are having the deposition of the mutated transthyretin again because of the gene mutation, which is a gene forming this transthyretin. Okay, so any doubt? The step one will ask you, and they will give you a disease like Alzheimer's disease, and they will ask you what kind of amyloid causing this disease. Okay, and what kind of amyloid is present in the primary amyloidosis, what kind of amyloid is present in the secondary amyloidosis, and they will give you a history of a patient having any of the chronic diseases like the autoimmune diseases or might be the cancer case, and they will ask you about this amyloid thing. Okay, and they can also give you the histology of the patient, and by the H&E staining, by the congruent staining, or by the apple green birefringence, and they can ask you what kind of a structure of this protein is. It would be the beta plated structure. Okay, so you just need to know the precursor protein of these amyloids. Okay, you need to know the location of the amyloids, and you need to know the stainings and the structure of the amyloid. That's it. Any doubt on the amyloidosis? Yeah,
No, sir.
It
yeah, ask.
is written in localized amyloidosis.
Yeah,
In the last, it is written systemic senile age-related.
yeah.
It is localized or systemic?
It is only it is named systemic because it is involving your heart. Okay, but it is localized only. It is localized completely, right? It only affects your heart ventricles. No other organ would be affected. But name localized because it is heart, and kind of heart is attached to every other organ by the blood vessels and all these things. That's why maybe the name systemic senile amyloidosis, but it is only limited to the heart. Okay, no other area.
Okay, how do we differentiate between this systemic senile amyloidosis and familial amyloid?
Age of the
Cardio-
patient. Remember the systemic senile, because it is age. It is only seen in the old age patients, right? But this familial amyloid cardiomyopathy will be seen in the young patients also, like 30s or 40s, right? So age is very important to differentiate. Okay,
Thank you.
this senile amyloidosis will only be seen after the age of 60 or 50, not in 30s and 40s. That's an easy way to differentiate between the two. Okay, so any doubt? Any other doubt?
No, thank you.
Then comes the inflammation. Okay. Okay, so why this inflammation is actually occurring in your body? Okay, why we require the inflammation? Okay, so whenever a damage or an injury to your body happens, it always followed by the inflammation. Why inflammation is occurring? In order to eliminate the cause of the cell injury. Whenever a cell injury happens, you know there must be a certain cause of it. For example, an infection or anything like that. So inflammation happens to eliminate the cause of the inflammation. Sorry, the cause of the cellular injury. Okay, and remember I told you whenever a necrosis happen, it always followed by the inflammation, by the neutrophils should also be there, right? And why? To remove the necrotic debris. Okay, so necrosis is always followed by the inflammation to remove the necrotic debris. Okay, third is the tissue repair. You will see in the wound healing part that wound healing is always required the inflammation. Okay, so you require the inflammation for the proper wound healing. So three things: to remove the cause of the injury, to remove the debris, and for the proper wound healing you require the inflammation. And inflammation is not always beneficial. It could always, it's sometimes could be inappropriate and can lead to the tissue damage also. For example, in case of autoimmune diseases, in case of a SLE, the inflammation is non-beneficial, right? In case of a granuloma formation, although this the granuloma is limiting the spread of the organism, but this granuloma also causing the tissue damage. Remember the cavity lesion in case of a TB, it is because of the granuloma, right? So the inflammation is kind of a beneficial, but can also become the harmful if the inflammation is too much, like in case of a septic shock, if the inflammation is prolonged, like in case of a tuberculosis, or if the inflammation is inappropriate type, like the autoimmune diseases. Okay. Then you need to know the signs of the inflammation, the cardinal signs that includes the redness and the warmth over the area. Whenever you have an injury, that area will become very warmth and very red. Why? Because of the vasodilation. When the vasodilation happens, the too much blood will flow through that area, and as a result, the redness of the area happens, right? And because of the blood flow of that area is increased, you will get the warmth over that area. Okay, and why the blood flow is increasing? Because of the vasodilation, of course. And what are the mediators of the vasodilations? These are the histamine, very much important, the prostaglandins, the bradykinin, and the nitric oxide. These four things are causing the vasodilations. And you need to know where the vasodilation ultimately happen in case of a artery. These are the arterioles. You will study that later in the cardiology section also. The maximum resistance inside the arterial system is always offered by the arterioles. So in order to dilate the blood vessels, you need to relax the arterioles. The smooth muscles in the arterioles, they need to be relaxed so that the vasodilation will occur and the blood flow would be increased, and done by the four mediators: the histamine, the prostaglandins, the bradykinin, and the nitric oxide. Second is the swelling in that area. And the swelling happens because of increase in the vasopermeability. And you need to know the location of the vasopermeability. This would be the post-capillary venules. Very much important. So the location of vasodilation is the arterial smooth muscles or the arterioles. And the location of the increase in vasopermeability would be your post-capillary venules. Okay, which forms after the capillaries. Okay, and as a result, all this blood will start filtering inside the interstitial spaces. Not the blood, but the plasma actually. The plasma will be started leaking from the blood vessels and entering into the interstitial space, forming the swelling in that area. Okay, then you need to know what kind of intermediates or the mediators can cause increase in the vasopermeability. That would be your histamine, again, the leukotrienes, the serotonin. Very much important, the leukotriene, the serotonin, and the histamine. You need to know the function of the prostaglandins and the leukotrienes, right? The prostaglandins who causes the vasodilation and the vasopermeability. Okay, and opposite to that, the leukotrienes will cause the vasoconstriction and increase in the permeability. Okay, so prostaglandins always dilates and leukotrienes always causes the vasoconstriction. And similarly, in case of lungs, they can cause the bronchospasms because they constrict the smooth muscles, right? They constrict the smooth muscles. Okay, and they can cause the permeability increase. Okay, and how the permeability increases? It is increased by increasing the space between the different endothelial cells. Okay, by increasing the space between the different endothelial cells, causing the increase in the fluid secretions or excretion, right? Leakage. So the location is the post-capillary venules, three type of intermediates or the mediators: the leukotrienes, the serotonin, and the histamine. Okay, then comes the pain. Okay, because your nerve endings will become very sensitized, they're causing the pain. And the most important mediator of the pain is your prostaglandin E2. Very much important. The most important mediator is the prostaglandin E2. And along with the prostaglandin E2, the bradykinin and the histamine can also cause the pain. Step one can ask you this: what mediators are causing the pain in case of inflammation? These are the bradykinin, the prostaglandin E2, and the histamine. Okay, and ultimately, because of this pain, because of this swelling, because of this redness in the area, you will get the functional loss of the particular area. Okay, very much important. Then the systemic manifestations, and this includes the fever. And you need to know the prostaglandin E2 is responsible for the fever. The prostaglandin E2 will increase the temperature set point in the hypothalamus. Okay, and the hypothalamus, which was working on the 37 degrees centigrade, the normal body temperature, now it will be start working at 38 or 39 centigrade, 38 or 39 degrees centigrade temperature now. Okay, and that is causing the fever, and it is mediated by the prostaglandin E2. And step 1 will ask you what kind of cytokines can increase the prostaglandin E2, and these are the interleukin 1, interleukin 2, and TNF alpha. Okay, interleukin 1, interleukin 6, sorry, not 2, interleukin 1, interleukin 6, and TNF alpha. They can cause the increase in prostaglandin E2 by the increasing COX activity. You will study later in the MSK chapter how this increase in the COX activity can lead to increase in the prostaglandin E2, and that prostaglandin E2 will increase the temperature set point in the hypothalamus. So now the body which was initially working at a 37 degrees centigrade temperature, the same body will be working at 38 or 39 degrees centigrade temperature, right? Again, another one is the leukocytosis, which is the elevation in the WBC point, in the count, and you require the interleukin 2 for the leukocytosis. Okay, you require the interleukin 2 for the leukocytosis. We have already discussed that in the immunology section also. Okay, and now the last one are the acute phase reactants or the acute phase proteins, and these are the proteins whose number will rise too much, or not the rise but also fall, right? So the change in number, I must say. So these are the proteins whose number change very drastically in case of any kind of inflammation. You call them the acute phase reactant proteins. Okay, and you need to know that interleukin 6 is responsible for these acute phase reactants. Okay, so the factors whose serum concentration changes very significantly in case of inflammation, these are the acute phase reactants. Okay, and you need to know that the liver will form these acute phase reactants, and they are formed both in the acute as well as the chronic inflammatory states. And one of them is the serum amyloid. We have discussed it, that it is an acute phase reactant. It is always secreted from the liver in case of an acute inflammation. But if the inflammation is persisted for too much period of time, it can form the amyloidosis, right? And now you need to know what kind of protein will elevate in case of inflammation, what kind of protein will decrease in case of inflammation, and what kind of protein will decrease or increase depending upon the type of inflammation. Okay, so the proteins which increases, one is the ferritin. Okay, the function of ferritin is to bind the iron and to sequester it so that no microbes can feed on the iron. Okay, remember I told you the infection of the Vibrio, that it required the iron to cause, to cause the infection. And that's why in case of a hemochromatosis or any kind of iron overload, we were having the very serious infection from the Vibrio. Okay, so it required the ferritin to sequester the iron so that no microbes can be thrive on your body iron. So it is a ferritin. That's why it need to be upregulated. Then comes the fibrinogen. Okay, and the fibrinogen is required for the coagulation, right? The fibrinogen is required for the coagulation, and it is the same fibrinogen which is responsible for the ESR. Okay, erythrocyte sedimentation rate. The fibrinogen will coat your RBCs, and as a result, the charge on the RBCs will be lost, and the RBCs now come closer very easily, increasing the ESR sedimentation rate. So the fibrinogen is responsible for the ESR. Then the serum amyloid A, we have discussed it. It is an acute phase reactant, and if the inflammation is persisted, it can lead to the amyloidosis. Then the hepcidin. Okay, the function of the hepcidin is to decrease the iron absorption and to upregulate the ferritin. Okay, and as a result, you will get a decreased iron absorption from the GI tract. You will get the increased sequestration of the iron by the ferritin, and ultimately the body iron stores would be reached, but the circulatory iron in your body would be lost, and as a result, you will get the anemia of chronic disease in case of a chronic diseases. So whenever you get a chronic disease, because there will be too much hepcidin forming inside the body, it will sequester every iron from the body, and the iron would be present for the use, and you will get the anemia of chronic disease. Okay, so if the step 1 will ask you what about the iron stores in case of hepcidin, so you will answer that iron stores will be too much. Iron is very much abundant in your body, but it's just that the free iron, which is the iron required for any kind of a function, is not available, right? And as a result, your RBCs cannot use the iron now. They cannot form the hemoglobin from that iron, and you will get the anemia of chronic disease in case of too much hepcidin. Then the C-reactive protein, which fixes the complements, and complements are required to fight the infection. So the C-reactive protein is also too much elevated in case of any kind of inflammation. Okay, and that's why you need to measure the C-reactive protein in any kind of inflammation, like the vasculitis, right? Then those proteins which are downregulated or decreased, first is the albumin. Okay, because you require the antibody formation, right? And antibodies are the proteins, and albumin is also a protein. So all the protein synthesis is now focused on the formation of antibodies, and as a result, this albumin would be decreased. Okay, so whenever there is an inflammation inside the body, you will have the decreased albumin count. Okay, the transthyretin, okay, it is also reduced. Okay, the transthyretin is basically the protein which transport your iron. This is also reduced because there is no free iron present in the body for the transport, right? Then comes the transferrin. Oh, yeah, sorry, it was a transferrin, okay, which transport the iron. Okay, this transferrin is also internalized by the macrophages, sequestered iron. Okay, so you will have the loss of albumin, you will have the loss of transferrin, and you will also have the loss of transthyretin, which is a protein present in certain tissues, like we have discussed that in the myelodoses also, the transthyretin. Okay, so and then comes the procalcitonin. It is kind of a protein, and the type of inflammation will determine if the level of this procalcitonin will rise or fall. In case of a bacterial infection, the procalcitonin level will rise, and in case of a viral infection, the level of procalcitonin will form. Very much important to know. Step 1 will ask you, okay, in case of a bacterial infection, the procalcitonin level will rise, and in case of a viral infection, the procalcitonin level will fall. They will describe you the similar scenario. They will describe you some kind of a protein which was increasing in case of a bacterial infection and decreasing in case of a viral infection. And they will ask you the name of this protein, and it would be the procalcitonin. Okay, so everything would be to memorize the positively regulated proteins and the negatively regulated proteins in case of any kind of a inflammation. And then you need to know what kind of cytokine causes this acute phase reactant formation. This would be the interleukin 6. You need to know the function of different acute phase reactant, the ferritin, the fibrinogen, the serum amyloid A, hepcidin, C-reactive proteins, albumin, transthyretin, procalcitonin. Okay, so any doubt in this page?
Can you repeat the fibrinogen function? Like how does it elevates ESR?
You will study that later in the next page also, but let me show you this. Just hold on a second. Let me annotate it. Okay, now see. This is your RBC1. This is your RBC2. Okay, they have this negative charge around them, right? And you guys know that negative always repels negative, right? And if a negative charge is present around the cells, then the cell will come closer very less or very slowly, right? And as a result, the ESR, the erythrocyte sedimentation rate, will be very much low because of this negative charge, right? Because negative repel each other, right? But if the fibrinogen is present inside the body, in case of inflammation, this fibrinogen will coat the RBCs. Okay, this fibrinogen will coat the RBCs, and as a result, this negative charge is now lost. And because the negative charge is now lost, these RBCs can come closer at a much faster rate, right? And as a result, you will get the high ESR, high erythrocyte sedimentation rate in case of a high level of fibrinogen. Now you understand it?
Yes.
It is just the rate of deposition of the RBCs. Okay, you will take you will
Thank
take the
you.
sample. You will take the sample of blood in the tube, and you will determine how much faster the RBCs are settling inside this tube at the bottom of the tube. Okay, and it will depend on the charge of the RBCs. If the charge is too much, it will take so much time for them to settle down in the bottom, and as a result, the sedimentation rate would be very much slow. But if this negative charge is lost, then they can come closer at a much faster rate, and that's why they will settle at a much faster rate in the bottom of the tube. So you will get the high ESR. That's about the fibrinogen and the ESR, how you can correlate between them.
Okay, thank
And
you.
yeah. And now let's discuss the erythrocyte sedimentation rate. We have discussed that already, that the RBCs are negatively charged. Okay, and because the RBCs are negatively charged, they always repel each other, right? Now, what's gonna happen in case of a products of inflammation, for example, the fibrinogen, it will coat the RBCs, and as a result, the negative charge around the RBCs would be lost, and as a result, the RBCs can be aggregated at a much faster rate and giving you the high ESR, right? And then you do know the different conditions which can cause the high ESR or a low ESR. So, okay, in case of a high erythrocyte sedimentation rate, if the charge on the RBCs are lost or the charge on the RBCs are kind of less, like in case of anemias, okay, so we'll get the high ESR in case of anemia, because in case of anemia, you are having this very few RBCs, and as a result, very few negative charge, so that they can come closer at a much faster rate, forming the high ESR. In case of infections, any kind of inflammation or any kind of infection can lead to the formation of fibrinogen. So you will get the high ESR. Okay. In case of cancer, you will get a high level of serum paraproteins, just like the fibrinogen. Okay. And these serum paraproteins will coat the RBCs, giving you the high ESR. In case of a renal disease, because in the renal disease, you are having this loss of proteins, right? The nephrotic syndrome. Okay, so you will get the inflammation also, and you will get the high ESR. In case of pregnancy, you can get the high ESR because of a dilutional anemia. Okay, then the conditions which lower the ESR, one is the sickle. Any kind of a change in shape of the RBCs, either the increase in size or the decrease in size or the abnormal shape, they will decrease the ESR always, right? So in case of a sickle cell anemia, because you're altering the shape of the RBCs, you will get the low ESR. In case of a polycythemia, because the charge on the RBC is now too much, because the RBCs are too much, right? So you will get the low ESR. In case of a heart failure, you will get the low ESR. In case of a microcytosis, because you're, like I told you, any kind of a change in the shape or size of RBCs can lead to the decrease in ESR. So in case of a microcytosis, you will get the low ESR. In case of hypofibrinogenemia, because the fibrinogen is required to coat the RBCs to cause the increased ESR, okay, you will get the low ESR in this case also. Okay, so any doubt in the ESR and the examples?
How does the heart
Yes,
failure?
Yeah, sir. So on the list of the high ESR, you have pregnancy for with dilutional anemia, right?
Yeah.
But then on the other decreased ESR, you also have dilute aggregation with increased RBCs. So can you explain the difference between these two different?
Please repeat it again.
Okay, in the ESR list, pregnancy, increased ESR due to dilutional anemia, right?
Yeah.
Okay, but then in the decreased ESR, you have polycythemia also with dilute factors. You have more RBCs, but again, you have like less of the factors, which is the same thing as pregnancy, right? Like I'm not getting the difference.
I'm not understanding your question. Can you please write it down?
Yeah,
in the
sure.
Yeah, please. Okay, so in pregnancy and polycythemia, both have dilution anemia. Why? No. In case of a polycythemia, you are having too much levels of RBCs, right? The polycythemia, which means a high level of RBCs, and if the RBCs are too much, then in that case the charge on them is also too much, you know? And that's why they will repel each other very much at higher rate, right? And that's why the ESR would be low in case of polycythemia because of too much RBCs, too much charge, and lower rate of deposition, right? So low ESR. But in case of a dilutional anemia, you're actually increasing the RBCs, but the concentration of the RBCs is so much low, right? And if the concentration is low, then they can deposit at a much higher rate. It's all about the concentration ultimately, right? In case of a polycythemia, the concentration is too much. That's why. Okay.
Sir, how is nephrotic syndrome related to high ESR?
Because in case of a nephrotic syndrome, you're having, first thing is a milder inflammation would be there in case of a nephrotic syndrome. And second is a loss of proteins is also happening, right? And all of these things combined can cause the high ESR.
Okay, sir.
Yeah. So
And
I think
why
we
in
can take a
end-stage renal disease?
yeah. Ask, please.
And why does ESR goes up? And why does ESR goes up in the end-stage renal disease?
Because in end stage renal disease, you're gonna have the inflammation in the end stage renal disease. You're gonna have the inflammation again. It's all about the inflammations. Okay. In the renal disease, you will have the
Okay,
inflammation that
and
can rise to ESR. This is a one-way thing.
okay,
One way to
so
get
we
the
can
high
take it
ESR.
like
Yeah.
wherever inflammation will go up, ESR will go up. Like,
Yeah, exactly. When the inflammation go up,
and
the
what about
ESR will go up.
heart failure?
Uh, Actually, it's kind of a research thing. I really don't know the answer behind it. I've tried to Google it before, but I didn't find any kind of answer. But there was a research which was showing that this ESR will actually form in case of heart failure. So yeah, I really don't know the answer exactly. I can send you a
Okay,
research paper if you want. I will send you the link.
okay.
Okay. Yeah. I think we can take a short break here. Yeah.
Yes.
Yes, sir.
Okay, so the acute inflammation we are discussing. Okay, the stimuli we have discussed, the mediators, okay, the complements and the Hagman factor. Because of the clotting, every inflammation requires a clotting also. So the Hagman factor, which is a factor 12, right? They are also take part in the acute inflammation. And ultimately the inflammasome complex is formed. It is a cytoplasmic protein complex, which recognizes like the dead cells or the microbes, okay, and causes the inflammation, right? And what are the components of the acute inflammation? First are the vascular components, and like I told you, in case of inflammation, the vasodilation will be happen so that the blood supply to that certain organ or certain tissue could be increased, so that the cells, the inflammatory cells and other proteins, other antibodies could be reach easily, right? The permeability of that area would be increased so that the cells can easily migrate from a blood vessel to the tissue. Okay, certain protein antibodies can also migrate. So vasodilation and vasopermeability would be here, right? And for the cellular, the extravasation of the leukocytes will happen, and you need to know the location to where the extravasation happened, and this would be the post capillary venules. Very important to know. The permeability happens in the these post capillary venules, and so that the extravasation of the leukocytes, mainly the neutrophils. You will study the process later in the next page. Okay, but just know the location for now, the post capillary venules. Okay, and this includes 4 steps. One is the migration, enrolling. Okay, second is the adhesion. Third is the transmigration, and fourth is the chemo attraction. Okay, so first is the migration rolling, second is the adhesion, third is the transmigration, fourth is the chemoattraction. And finally, the outcomes, either the inflammation is resolved or the infection or the cause of injury is resolved, so that the healing cytokines could be released like interleukin 10 and TGF beta. Okay. Second thing, the inflammation could be persisted. If the cause of injury is still not resolved, then what's going to happen after 3 days? The macrophages will become, okay, and they will check for the inflammation, and if they require the more inflammation is required, if they feel like, then they will release the interleukin 8. And you guys know the interleukin 8 is a neutrophil chemoattractant, right? So it will attract more neutrophils, it will cause more inflammation, right? Third thing, the abscess formation, because of the release of these hydrolytic enzymes from the neutrophils, they will form the abscess. And you guys already know that abscess is a liquefactive necrosis, and it is always walled off by the fibrosis, so that a limited area could be abscissed only, not the whole area, right? Fourth thing, if the inflammation is kind of inappropriate type, okay, then ultimately what's going to happen, the macrophages will present the antigen to the CD4 cells, and now the CD4 cells will be activated. They will control the inflammation and they will form the chronic inflammation. Okay, so what's going to happen when the injury occurs? Within 1 to 3 days, the neutrophils would be there at the site of injury, right? And they will clear the cause of injury. They will clear the debris. Okay, after 3 days, the macrophages will arrive at that location. They will check the location, and if they feel like the inflammation is no much required, then they will release the interleukin 10 and this TGF beta to shut down the inflammation. And if they feel that more inflammation is required, more neutrophils are required, then they will form the interleukin 8. They will secrete it. They will attract more neutrophils. If they feel like that neutrophils are not enough for that kind of inflammation, for that kind of infection, then they will present the antigen to the CD4 cells after 3 days. Okay. And the activation of the CD4 cells will occur, and it will cause the chronic inflammation. And finally, after the inflammation, if the tissue had the regeneration capacity, then the complete regeneration will occur. If the tissue loses its regeneration capacity, then the scarring would occur. Okay, so these are the outcomes of any inflammation. Any doubt on the second inflammation?
On
Can-
your handwriting, where you
Yeah.
say antigen, the antigen activates CD14, what is that after CD14? Toll-like receptor,
Pardon, please.
TLR.
The toll-like receptors.
You got the
Yes.
number 1.
Yeah. Well, this is
TLR.
the end. Okay, so you remember the function of these toll-like receptors? Remember they recognize the PAMPs.
Yes, but what
Okay,
it says is
so
TLR, toll-like receptor.
you can write it down, if you can, please, in the chat box. Please write it on the
Okay.
chat box so that I can easily understand it, what I'm trying to say. Okay. Yeah, it is toll-like receptors which recognize the PAMPs, the CD14. I've told you about this, right?
Okay. Yeah, okay.
It is a
Thank you.
toll-like receptors only.
Thank
And
you.
these are the first receptors which recognize the type of pathogen it is, right? And they will generate the response by secreting the NF-kappa B. And NF-kappa B does two things. One is the release of interleukins or the cytokines, and second is the arachidonic acid metabolism pathway, the COX pathway that you guys know. And it will generate the leukotrienes and the prostaglandins, and further other things will happen, right? So these are the toll-like receptors.
Okay, thank you.
Okay, now the process of the leukocyte extravasation, or I must say the neutrophil extravasation, because most commonly neutrophil extravasation occurs, right? So it includes 4 steps like we have discussed. One is the migration and rolling. Second is the tight binding. Third is the diapedasis or the transmigration. And fourth is the migration or the chemotaxis. Okay, so what's going to happen? The neutrophils were, freely moving inside the blood vessels, very, at a very high speed, right? And whenever there is an inflammation, the inflammation will form 2 things. One is the E-selectin, and second is the P-selectin. Okay. The E-selectin is formed by the cytokines which released from the damaged cells or from the inflammatory cells itself, like macrophages, the TNF alpha and the interleukin 1. They will upregulate the E-selectin in the vascular endothelium. Okay, and second is the P-selectin, which is released from the viable bloody bodies. Okay, these viable bloody bodies are found in the platelets and as well as in the endothelial cells of the blood vessels. And these are the same viable bloody bodies which also secretes a von Willebrand factor. Okay, so 2 functions for the viable bloody bodies. One from W, it is the von Willebrand factor, and second from the P, it is the P-selectin. Okay, now both these E-selectin and P-selectin will bind to the Salal-Lewis X on these neutrophils. Okay, so neutrophils has some kind of a receptor or some kind of a proteins. These are the Salal-Lewis X. They will bind to the E-selectin and P-selectin, and it is kind of a speed breakers. And now the moving cells will start rolling, as you can see, after attaching it. Okay, and once the rolling start, now then other type of proteins, which are the ICAM proteins, intercellular adhesion molecules, okay, they will be upregulated by the TNF alpha and interleukin 1 itself. Okay, they will be present on the endothelial cells, and now they will bind to the integrins or the LFA1 or the MAC1 or the CD18 on the neutrophils. Okay, this is very important. The integrin, LFA1 or the MAC1. Remember the one deficiency, which is a leukocyte adhesion deficiency that occurs due to the loss of the CD18 integrins. Okay, and the other name includes the LFA1 or the MAC1. Okay, if the deficiency of these integrins happen, then the rolling would be normal, but the tight binding won't occur. And if the tight binding won't occur, then the diapedasis or the migration cannot be occur. And as a result, you will get the leukocyte adhesion deficiency, in which you will have this no abscess, but the skin infections without abscess. And the delayed falling of the umbilical cord and persistent infections would be there, right? So this is because of the loss of CD18. Okay, and this CD18 will bind to the ICAM molecules as well as the VCAM molecules also. Remember the virus which bind to the ICAM receptors? Remember the name of virus?
Rhino.
Rhinovirus.
Yeah, rhinovirus. I came to see rhino, if you the mnemonic to remember it, right? So these ICAM molecules are found on the endothelial cells of the blood vessels, right? And now the tight binding is occurred. The moving neutrophil is now stopped. Okay. Now what happens? There is another type of proteins found on the neutrophils and as well as on the these blood vessels, which are the PCAM1. Okay, so PCAM1 on the neutrophils and PCAM1 on the endothelial cells. Now using these receptors, the neutrophils can easily transmigrate through the blood vessels. And where this transmigration is occurring? At what location? In the blood vessels?
Post capillary venules.
Exactly, the post capillary venules. And through the post capillary venules, they will exit the blood vessel and enter the tissue space. Okay, now the release of different type of cytokines like C5a, which is a complement factor 5a, the interleukin 8, and the leukotriene B4. Remember the chemotactic factors. Now they will be secreted from the inflammatory sites and they will attract the neutrophil to reach at the site of inflammation. Right? So these are the 4 steps which of your leukocyte extravasation. And most important one to remember is the integrin function. Okay, it causes the tight binding, and without it, you can have the leukocyte adhesion deficiency type 1. Okay. Same process is followed by the macrophages also. Same process is followed by the other WBC cells. Okay. And at the site of injury, at the site of inflammation, in the neutrophils, the major pathway is the oxidative burst. Okay, after the ingestion of the microbe, it could be killed by the oxidative burst, and by the release of potassium ions, if you guys remember, it will activate the lysosomal killing, which is a minor pathway. But in case of macrophages, the lysosomal killing is the major pathway. Very much important to remember. Okay, so any doubt on this leukocyte extravasation?
Can you repeat that last thing you said?
Okay, remember I told you about this oxidative burst or the respiratory burst in the immunology section? I've told you that this
Yes.
oxidative burst is the major pathway of killing any microbe in the neutrophils, right? And when the oxidative burst was generated, the potassium ions are also secreted, and these potassium ions activate the lysosomal killing also. You can refer to the page on the immunology section, the first aid. Okay, they will secrete the potassium ions that will activate the lysosomal killing. But this lysosomal killing is the minor pathway in neutrophils. In case of macrophages, when they ingest any microbe, the lysosomal killing is the major pathway in macrophages.
Okay.
Very much important. Okay. So yeah, that's about the leukocyte extravasation. And you guys should also know that this integrin is upregulated by the C5a or leukotriene B4. The same interleukins or the chemokines which causes the neutrophil chemotaxis. The C5a and the leukotriene B4, they are responsible for the CD18 or the integrins upregulation, right? And for the blood vessels, the ICAM molecules, they are upregulated by the TNF alpha and the interleukin 1, which are secreting from the site of injury. Okay, that's about it. Now the chronic inflammation, and the hallmark feature of the chronic inflammation is the presence of macrophages and the lymphocytes. Whenever whenever the step one give you any histological slide, and they will show you the macrophages or the lymphocytes, then it is very important to know that this must be the chronic inflammation, because the hallmark feature of the acute inflammation is neutrophils. Doesn't matter what time it is, how much months have passed, how much year have passed. If the neutrophils are there, that means it is a acute inflammation. And if the macrophages and lymphocytes are there, or the plasma cells are there, that means it is a chronic inflammation. Okay. And in case of a chronic inflammation, simultaneous tissue destruction as well as repair is occurring. Okay. So in case of a chronic inflammation, tissue destruction as well as tissue repair, both things are happening at the same time. Okay. But in case of a acute inflammation, there is always tissue destruction happen. No repair or no regeneration happens in the acute inflammation. But in chronic, both things are happening at the same time. Right. And this chronic inflammation can be followed after the acute inflammation, or this chronic inflammation can be generated without the acute inflammation. Very important to know. This chronic inflammation can happen without or with acute inflammation also, after the acute inflammation, of course. Okay. So the infections like TB, like Treponema pallidum, certain fungi, and certain viruses, no acute inflammation happen in these scenarios. Only thing you will get is the chronic inflammation. Okay, the autoimmune diseases which are kind of very much prolonged or very much chronic, these are the example of chronic inflammation. Okay, prolonged exposure to certain toxic materials like silica, in case of a silica mining, okay, which is a foreign body type thing, you will get the chronic inflammation in the lungs that can lead to the fibrosis. Why fibrosis? Because the healing as well as the inflammation, both things are happening at the same time. So along with the inflammation, you will also get the fibrosis or the scarring in the lung, because it is a chronic inflammation, right? Mediators, like I told you, the macrophages are there and the lymphocytes are there. The macrophages are dominant cells which interact with the T lymphocytes, causing the chronic inflammation. The Th1 cells and Th2 cells, two type of cells are there. Th1 cells, they will release the interferon gamma and interleukin 2. Interferon gamma activates the macrophages, and they help the macrophages forming the granuloma. If you guys remember the immunology section, the Th2 cells, they will release the interleukin 4 and interleukin 13 also. Okay. And remember the function of interleukin 4? What kind of antibodies it generate?
IgE
And
eosinophils.
not the eosinophils, but IgG and IgE are generated by the interleukin 4, and IgA and eosinophils are generated by the interleukin 5. Okay. And so what are the outcomes of the chronic inflammation? Either it can lead to the scarring, and like I told you, if the inflammation is persisted for a prolonged period of time, the serum amyloid A will start depositing inside the tissues, right, outside the cells. And that can lead to the amyloidosis. And ultimately, this chronic inflammation can also form the cancer. Like in case of a chronic hepatitis C virus, you can have a chronic inflammation and that can lead to the hepatocellular carcinoma. In case of a H. pylori, you can have a gastric adenocarcinoma, if you guys remember. Okay. Oh, so that's about the chronic inflammation. The most important thing to remember is the simultaneous tissue destruction and repair. And second most important is the type of cells which are involved in it, the hallmark features. And why you get the fibrosis in the chronic inflammation is very important. Okay, the mediators that they release, the cytokines, the cells are involved. Okay, and the outcomes that could be the scarring, amyloidosis, and cancer. Three things. Any doubt in chronic inflammation?
I got a question. You say
Yeah.
Th1 secretes interferon gamma and interleukin 2?
Yeah.
Okay, because interleukin 2 is not in the book, so just
Yeah, not in the book, but if you refer back to the immunology section, I've told you about this. When the Th1 cells are activated, they release the interferon gamma as well as interleukin 2. And interleukin 2 will increase the number of macrophages, B lymphocyte, T lymphocytes, neutrophils also even. Okay, and the interferon gamma will activate the macrophages to kill the intercellular pathogens and to form the granulomas. If you remember this line from the immunology, right?
thank you.
So now the wound healing, and like I told you that acute inflammation is always required for the wound healing. Without the acute inflammation, you cannot have the wound healing. Okay, so what is the normal process of the wound healing? So first thing is the injury. Okay, and once the injury would occur, there would be the homeostasis, very much important. There would be the blood clotting to prevent the blood loss. Okay, step one will ask you this process completely. So it is not just 3 steps, but before them, the injury would occur, and after the injury, the blood clotting will also occur, right? And soon after the blood clotting, the inflammatory phase will start. Okay, and after this uh, uh, after this inflammatory phase, the proliferative phase will start after 3 days or 3 weeks later. Okay, and after the proliferative stage, finally the remodeling phase will start. Okay, so please remember all these steps. One is the injury, second is the homeostasis, which is the blood clotting to prevent the blood loss, third is the inflammation to eliminate the cause of injury and to promote the wound healing, and third thing is to remove the cellular debris, if you guys remember from the previous pages. Third is the proliferative phase, in which the formation of protein, deposition of collagen will all occur. In case of a remodeling stage, this the collagen would be remodeled to other type of collagen so that more strength could be generated in that particular area, right? So the 4 steps of the wound healing. Then you need to know the mediators, okay, which causes the wound healing, which are involved in the wound healing. Okay, one is the fibroblast growth factor, and fibroblast growth factor do not cause the fibrosis. Please remember, fibroblast growth factor do not cause the fibrosis. They causes the angiogenesis. They will cause the formation of blood vessels. Okay, the TGF beta, they will cause the fibrosis as well as the formation of blood vessels, the angiogenesis. Okay, and you need to know the difference between the interleukin 10 and TGF beta. Many of you might be confused between these two. So interleukin 10 is only involved in the suppression of any immune response. Okay, but TGF beta is responsible both for the suppression of immune response and for the fibrosis. Okay, that is a huge difference between interleukin 10 and TGF beta. They both are involved in the suppression of immune response, in the suppression of inflammation, but only TGF beta takes part in the wound healing pathway. Okay. Third is the vascular endothelial growth factors, and these VGEF, as the name suggests, they will cause the angiogenesis because endothelium is formed during the blood vessel formation. So vascular endothelial growth factors. Then comes the platelet-derived growth factors. They do not take part in the angiogenesis. Please remember, they do not take part in the angiogenesis, but what they causes is the smooth muscle cell migration. You will study that later in the atherosclerosis pathway also, that this platelet-derived growth factor actually activate the smooth muscles to migrate and form the cap around the atherosclerotic plaque. If you guys remember, the cap is formed by the migration of smooth muscles and the release of this the collagen and other fibers from the smooth muscles to form the cap. So it is done by the platelet-derived growth factors. So they're responsible for the smooth cell migration. Okay. And they also stimulate the fibroblasts for the collagen synthesis. Then comes the metalloproteinases. Okay. And you need to know that zinc is the cofactor which is required to activate the metalloproteinases, and they causes the tissue remodeling. They will degrade the collagen. They will convert one type of collagen into another type of collagen so that more strength could be provided at the site of injury. Then comes the epidermal growth factors. Epidermal growth factors, unlike the VEGF, they do not take part in the angiogenesis. Okay, but they provide the cell growth. Okay, they will activate the tyrosine kinase pathway. Okay, and ultimately provide the epithelial growth, as the name suggests, epithelial growth factors. Okay, so please remember their function: VEGF, not the FGF, but the VEGF and TGF beta. Okay, for the angiogenesis, epidermal growth factor for the cell growth. Okay, TGF beta for the fibrosis and the angiogenesis. Okay, it is not FGF is not there. Just cross it. Okay. So yeah, these are the mediators of the wound healing. Now comes the phases. Now, first phase is the homeostasis, which you will discuss in the hematology section, the clotting factor formation and the formation of clotting completely to prevent the blood loss. Second is the inflammatory phase. The neutrophils will reach at the injury site. Okay, and the neutrophils will start eliminating the microbes, and they will start clearing the debris of the cell. Okay, and the platelets will also reach there for the homeostasis. The macrophages will also reach there, and they will activate the neutrophils and they will tell them what to do. Okay, and as a result, the clot formation will occur, the vasopermeability will occur, the vasodilation will occur, neutrophil migration will occur, and after 2 to 3 days later, the macrophages will reach at the inflammatory side, and they will decide whether to continue the inflammation or to inhibit the inflammation for the wound healing, right? Like I told you already. Okay, and you require the inflammation for the wound healing, but if the inflammation is too much or the inflammation is persisted for a prolonged period of time, then the wound healing won't happen. Okay, and the similar thing is happened in case of diabetes mellitus. In case of a diabetes mellitus, you have this milder inflammation going inside your body for a prolonged period of time, and as a result, the anti-inflammatory cytokines, which are the interleukin-10, would be decreased in your body, and as a result, in case of a diabetes, you will get the delayed wound healing. So if the step 1 asks you why the delayed wound healing in case of diabetes, it would be due to the loss of anti-inflammatory cytokines because of this persistent inflammation that is going inside the body because of this diabetes thing. Okay, very much important to know. Then the next phase is the proliferative phase. It starts when the neutrophils are gone, when the neutrophils have cleared the debris, when the macrophages are not decided to end the inflammation. Okay, it would take a minimum of day 3 because up to the day 3 there would be the inflammatory phase. Okay, and it can take up to like 1 month. Okay, for the proliferative phase to be happening. Okay, and in this phase, the fibroblast will reach at the site. The fibroblast will cause the fibrosis. They will release the collagen at the site, and they will also take part in the angiogenesis pathway. Okay, and by the modification of the fibroblast, you will get the myofibroblast, which causes the wound contraction. Okay, so that the edges of the wound could become closer for the healing. Okay, third come the endothelial cells, which are formed by the VEGF, and they take part in the angiogenesis. The keratinocytes, okay, which with the help of this epithelial growth factor will regenerate, will multiply, and will form the skin over it. The macrophages would also be there, guiding every cell. Okay, and like I told you, the myofibroblasts are derived from the fibroblast. They're contracting the wound. Okay, in the proliferative phase. But if too much of the myofibroblasts are there, okay, if too much of the myofibroblasts are there, then they can form the contracture formation. If you guys remember the name Dupton contracture, it is happened because of very high activity of the myofibroblasts, that they will contract too much and causing the contracture formations. Very much important. Step 1 will ask you why the contracture formations are occurring. It is because of the myofibroblast, and in which phase? It is in the proliferative phase. Okay. And yeah, because you require the collagen in this proliferative phase. Okay, and the most important type of collagen is the type 3 collagen. Okay, because it is very stretchy and it's the initial collagen in the wound healing phase. So you require the vitamin C for the formation of collagen, if you guys remember. Okay, in case of a vitamin C deficiency, you will get the delayed wound healing. Okay, because of loss of collagen. Okay, so in the proliferative phase, you will see the granulation tissue. And what is the hallmark feature of the granulation tissue? This is the presence of blood vessels. So whenever a step 1 will give you any histology of a certain injury or a certain wound, and in this wound, they would be showing these blood vessels, multiple blood vessels inside the wound area. So this would be the granulation tissue, and the patient must be in the proliferative phase. Very much important. Okay, and yeah, the angiogenesis would be there, and the epithelial cell proliferation would be there, the dissolution of clot would be there, and the wound contracture would be there by the myofibroblasts. And like I told you, the blood vessels are the characteristic thing in the granulation tissue. Okay, then comes the remodeling phase, in which the degradation of this type 3 collagen occurred. Okay, and the change of this type 3 collagen happened into the type 1 collagen, because like you all guys know that this type 1 collagen is the strongest collagen, right? So they will increase the tensile strength of the tissue. And because the metalloproteinases are required in this step, okay, so what you will see is the use of zinc. And in the zinc deficiency, you will get the delayed wound healing. Okay, and of course the fibroblasts are also required to synthesize the type 1 collagen. So type 3 collagen is kind of removed by the metalloproteinases, and this type 3 collagen is replaced by the type 1 collagen by the fibroblasts. So this is the remodeling phase. Okay, very much important to know. In case of a foreign bodies, let us suppose there was a wound happened. Okay, and the wound is kind of sutured by the sutures. Okay, and if the surgeon is uh, is kind of forget to remove the sutures, so now the sutures are the foreign bodies, right? And because of the foreign bodies, if the foreign bodies are not there, remember from here, the foreign bodies are the cause of this acute inflammation. Okay, so if the surgeon are forget to remove the sutures, what gonna happen? The foreign bodies would be persisted, and as a result, the inflammation would be persisted, right? And what can happen is the delayed wound healing. Okay, and ultimately, because of this foreign body formation, the patient can get the granuloma formation. Very much important to know. Step 1 will give you a certain scenario in which the patient got this wound, and the wound is sutured, and after 4 or 5 weeks later, you know, because surgeon was forget to remove the sutures, even after the 4 or 5 weeks later, the patient has this persistent inflammation. Why? Because of the foreign bodies. And they will also show you the histology, and in the histology you can see the granuloma formation. Very important. Okay, so always look for a patient with wound and suture are placed in them, because suture are the foreign body, and foreign body can lead to the acute inflammation, and you can always form the granulomas also. Okay, and if you give the patient cortisol, you guys already know that cortisol inhibit the neutrophil migration. They will cause a lymphopenia. They will suppress the immunity of the patient. And because a small amount of inflammation is required for the wound healing, so in case of a high cortisol, like in the case of Cushing syndrome, okay, or the patient who is on the glucocorticoid therapy, they will get the uh, delayed wound healing. Okay, because it will impair both the inflammatory stage and the proliferative stage of the wound healing. Very much important to know. And it is the remodeling phase in which the TGF beta is secreted. Okay, because the TGF beta is required for the collagen synthesis for the fibrosis formation, right? So the scar formation and the keloid formation, they always takes place in the remodeling phase. Very much important. The keloid or the scar formation that takes place in the remodeling phase of the wound healing. Okay, so it would be a patient who always comes after the month after the wound formation. Okay, so if they give you a timeline, because timeline is kind of very important, right? If the patient come to the emergency department or the OPD 3 or 4 days after the after the injury, then the patient must be in the inflammatory phase. If they come after 1 month and they will ask you what kind of a stage is going on inside the patient, so this must be the proliferative phase. Okay, and the patient if come after a kind of after 1 month or 3-4 months, then the patient is entered in the remodeling phase. Very important to remember the timeline. Okay, inflammatory phase, it takes up to 3 days, 4 days, and if the inflammation is persisted, it could take up to 1 or 2 weeks also. In case of a proliferative phase, it would take only 1 month. After 1 month, the patient would be entered in the remodeling phase. So you can either choose the option by looking at the timeline, or you can choose the option by looking at the hint. Okay, what kind of histology is given, what kind of a, if the scar formation, if the blood vessels are there, or some other thing, if the inflammation is there. So either looking at the histology or looking at the timeline, you can see if the patient is in any kind of a phase. Okay, so any doubt in this wound healing? Anyone, any doubt?
No.
No.
You just need to remember which phase occurs when, and what histology is present in what stage, and what kind of cells are involved in what stage, and what kind of mediators are involved in what things formation, right? Then you need to know about the granuloma formation. Okay, we have discussed the chronic inflammation also already, that this antigen presenting cells will present the antigen to the Th1 cells. They will release the interleukin 12 so that the Th1 cells could be activated. The activated Th1 cells will release the interleukin 2 and the TNF alpha. The interleukin 2 will increase the cell numbers of the macrophages, lymphocytes, and that interferon gamma will activate the macrophages to kill the intercellular microbes and to form the granuloma, right? And the granuloma is an example of chronic inflammation. You guys already know this pathway, right? So the granuloma can be induced by the persistent T cell response to a certain infections like the TB, sometimes foreign bodies also, and it is also related to the immune mediated diseases, right? And why the granuloma formation is occurring? To seal off the microbe, okay, to seal off the microbe or the stimulus, okay. And you need to know that it can the stimulus or the microbe cannot be completely eradicated by the granuloma. Okay, the granuloma is kind of a jail thing. Okay, it is holding the microbe at this place only. If the granulomas are not there, then the microbes could be disseminated completely inside your body, right? But the granulomas are there to hold off that organism in one place. But this granuloma can never completely eradicate that organism, right? And because the persistent inflammation is there in the granuloma, what you will get is the release of cytokines at that area, right? And because of the cytokines, the patient will get the fibrosis and the organ damage. For example, the cavity lesion in case of TB, it is not due to the toxins released by the mycobacteria, but due to the granuloma formation. And that granuloma formation will release cytokines that can damage the surrounding areas, causing the cavity lesion, right? Now, the histology of the granuloma, like I told you, the hallmark feature of the granuloma is the epithelioid cells, and it is the focus of the in the center of the granuloma. As you can see here, this is a complete granuloma. In the center of the granuloma, as you can see, this is the epithelioid cells everywhere. At some areas, you can have the giant cells also like that. Let me zoom it. I think you guys can see this. These are the giant cells. Okay, and in the center of the granuloma, because it is a complete granuloma in this picture, the center would always be the epithelioid cells. Okay, then comes the giant cells, and at the periphery there would be the lymphocytes, because it is a chronic inflammation. So no neutrophils, but the lymphocytes at the periphery, and in the center it would be the epithelioid cells. What are the epithelioid cells? These are the activated macrophages with abundant cytoplasm. Okay, and they are surrounded by the multinucleate giant cells, which are formed by the fusion of the activated macrophages. Okay, and they're also surrounded by the lymphocytes. So two type of granulomas are there. One is the caseating, and second is the non-caseating. the histology that is given here, it is an example of non-caseating granuloma, because you're not seeing any kind of necrosis here, right? If the necrosis is here, then this whole area in the center would be completely pink without any cell. And surrounding the pink area, there would be the epithelioid cells. And surrounding the epithelioid cells, there would be the giant cells and lymphocytes. But as you guys can see, that everywhere you see, there's the cells present, right? So it is a non-caseating granuloma without any necrosis. And it is seen in the autoimmune diseases like sarcoidosis, like Crohn's disease. The berylliosis is also a non-caseating granuloma. Then comes the caseating, in which the center part is the necrosis, and surrounding the necrosis would be your epithelioid cells. Surrounding the epithelioid cells would be the lymphocytes and giant cells. It is always seen in the infectious etiologies for like the systemic fungus and the tuberculosis, right? So this is very important. The mechanism we have already discussed, okay? And you also need to know that these activated macrophages inside the granuloma, they have this 1-alpha hydroxylase activity. Okay, they have the 1-alpha hydroxylase activity. So it will convert the 23 hydroxy vitamin D into 1,23 hydroxy vitamin D, which is the activated form of the vitamin D. So in case of a persistent granuloma formation, you will get the hypercalcemia. And the step 1 will ask you why the hypercalcemia is occurring in case of this granuloma, in case of a sarcoidosis, for example. So you will get what? Because of the macrophages. They have this 1-alpha hydroxylase activity. Okay. 1,21 hydroxy vitamin D you will get. Any doubt in the granuloma?
Yeah. What are other examples of caseating granulomatous diseases?
Certain bacterial infections are also there. For example, the this what you say, the bacillary angiomatous. What bacteria was that?
Bartonella Hansel.
The Bartonella hanselae. You will get a caseating granuloma in case of a Bartonella hanselae. In case of a brucellosis, you will get the caseating granulomas. Okay, and you will study. We will study later also again here the causes, the infectious and the non-infectious causes. Okay, in case of infectious causes, the bacterial, the mycobacteria that you guys know, the Bartonella hanselae, which causes the cat scratch disease, and a special type of granuloma is present in case of a Bartonella hanselae. It is a stellate necrotizing granuloma. Very much important. It has a very stellate shape, starry shape. It has very much important to know. The granuloma in case of a Bartonella hanselae would be like this. Okay, not the regular circular shape, but this kind of a shape is there in case of Bartonella hanselae. The Listeria monocytogenes, remember the disease, the granulomatosis infantis septica. If the infection of the Listeria is happen at a very early stage of the pregnancy, then the patient could get this disease, right? So Listeria monocytogenes is an example of granuloma. Treponema pallidum, the syphilis, the gommas that you know, all the gommas are nothing but the granulomas, right? The fungus, all these endemic mycosis, the histoplasma, the coccidomycosis, the blastomycosis, they are all example of granulomas. They can all form the granulomas. And the parasites, like I told you, schistosomiasis, which is not Th1 but a Th2 mediated granuloma, right? So these are the infectious causes. The non-infectious causes, they include the sarcoidosis, all the autoimmune conditions like sarcoidosis, the Crohn's disease, the primary biliary cholangitis, and that's why I told you this primary biliary cholangitis in the type 4 hypersensitivity section, because they have the histology same as that of type 4 hypersensitivity. Okay, the thyroiditis and the subacute or the decuvariant thyroiditis, you will have the granuloma in it also. Okay, which happens after the infection is over, right? Post-infectious thyroiditis. You guys can say it like that. And the granulomatosis with polyangiitis, which is the vaginous vasculitis, it is an example of granuloma. The eosinophilic eosinophilic granulomatosis with polyangiitis, or the Schreck-Strauss disease, in which you have the eosinophils and the granulomas. It is an example of vasculitis in the granuloma. The giant cell or the temporal arteritis is an example also. The Takayasu arteritis is the same example. Okay, certain foreign bodies like berylliosis, in case of the lungs, if you guys remember, it can cause a fibrosis in the lungs, the paralysis. Okay, it can cause a granuloma formation and the chronic granulomatous disease, the hypersensitivity pneumonitis. You will get the poorly formed granulomas in it. Very important, in case of a hypersensitivity pneumonitis, you will get the poorly formed granulomas because all the symptoms and everything is similar to that of sarcoidosis in case of hypersensitivity pneumonitis. But in case of the hypersensitive pneumonitis, you will get the poorly formed granulomas. In case of sarcoidosis, you will get the complete granuloma formation. That's how you can easily differentiate between the two in the lung symptoms, right? So that's about the granulomas completely, the cause, the examples, the pathology, the complete process we have discussed, right? And we have discussed the histological features. We have discussed the types. We have discussed the hallmark feature. Okay, what other cells you could see? Lymphocytes, not the neutrophils, because it is not a acute but a chronic inflammation, right? Yeah, most of the infectious etiologies makes the caseating, but some infectious etiologies are also there. I don't actually know the name right now, but they can also form the non-caseating type granulomas. But most of them that you studied here, almost everything, they all form the caseating granuloma. Okay, every infectious etiology here forms the caseating type granuloma. So any doubt other than this? Any doubt on this page?
No.
Okay, so then comes the scar formation. Scar formation occur at which stage of wound healing? Please tell me.
Proliferative.
Remodeling.
Not the
Sorry,
proliferative
remodeling.
phase. Remodeling phase,
Remodeling.
yes. So every scar formation that you study here, the two types, the hypertrophic or the keloid scar, they always form in the remodeling phase of the wound healing. Okay, so scar formation only occurs when the tissue loses its regenerating capacity. Very much important to know, because if the tissue has a regenerating capacity, then the stem cell will proliferate and no scar formation will happen. Okay, the tissue will become exactly similar to what was it before the infection or the inflammation. For example, in case of a lungs, if you get the pneumonia, you can either get a complete regeneration of the tissue, no sign would be left of the inflammation. But if the stem cells are lost in the area, okay, which are the type 1 or type 2 pneumocytes? Please tell me. The stem cells of alveoli, type 1 or type 2 pneumocytes?
Type 2
One.
pneumocytes.
Okay, yeah. If the type 2 pneumocytes are lost in the inflammation, then the scarring will occur in case of the lungs, right? So please remember, if the tissue has a complete regeneration capacity, then the healing will occur by the regeneration. But if the stem cells are lost, then what gonna happen? Only the fibrosis or the tissue repair will occur. Okay, because ultimately the goal of this scar formation is to provide the tissue strength, the collagen which provides the tissue strength, right? So you need the tissue strength for that. For example, in case of a myocardial infarction, because every cell in the muscle, sorry, because every muscle cell in the heart, it is a permanent type of cells. Okay, so they cannot undergo the regeneration. So the only thing that you will get in the myocardial infarction is the scar formation, and the scar formation occurs to provide the tensile strength to the heart, right? So the ultimately goal of the scar formation is to provide a tensile strength. Okay, and that 70 to 80% of the tensile strength is regained in 3 months. Rest will regained after like years later also. Okay, and for the scar formation, the only thing that you need to know is the TGF beta role. Okay, so TGF beta will involve in the fibrosis. If you guys remember from the previous page, this we have discussed that the TGF beta will form the fibrosis. Okay, very much important to know. So the two type of scars could be there. One is the hypertrophic scar, and second is the keloid type of scar. Okay, hypertrophic scar only occur when the wound, when the margins or the borders of the wound are very much close to each other. For example, in case of a surgical wound, okay, and so the extent of the scar is like limited to the wound areas only, confined to the border of the original wound only, right? And the collagen organization is always parallel. Let me annotate for you. If you zoom on this figure, come on, just hold on a second. Yeah. if you guys zoom here and see, then you can easily see that the formation of collagen in this area is happening like this. See, you guys can appreciate that, right? So the collagen synthesis or the collagen deposition in case of a hypertrophic scar is always occur in the parallel direction. Okay, always occur in the parallel direction. Very much important. Okay, in case of a hypertrophic scar, sorry, in case of a keloid scar, the deposition occurs is kind of disorganized. Okay, there is no proper shape or a pattern of the deposition. They are just depositing like that only, like in a disorganized way. Okay, and the collagen that is present in the hypertrophic scar is only type 3 collagen, but in case of a keloid it is a type 1 and as well as type 3 collagen. Okay, and why is the keloid and the hypertrophic scar formation occurring? Because of the excess TGF beta. Okay, because of the excess TGF beta. Okay, and you need to know that the incidence of this keloid scar formation is increased in the ethnic groups with darker skin. Okay, so in the step 1, okay, in the step 1, the patient with the keloid scar is always gonna be a African American or a dark skin individual. Most important to know, they will always give you a African American patient or a dark skin patient whenever they want to give you a case of keloid scar formation. Okay, and this keloid scar formation occur very frequently whenever the patient undergo any kind of a ear piercing or any kind of a surgery or any kind of a injury. The keloid scar will form there. So patient will present you always with a multiple histories of the scar formations. Okay, very much important to know. So a case would be a patient who is African American or a dark skin individual, and they will tell you that they have the history of this type of scar formations very frequent. For like 3-4 months earlier, the patient undergo the ear piercing and he developed this kind of a scar over the earlobe. Then the patient has this kind of injury on the knee and the patient developed this scar. And now after the surgery, the patient is also developed this keloid type of scar. So they will ask you what is the reason behind it. It is because of the excessive TGF beta activity. They will ask you what type of collagen is involved. It will be a type 1 collagen as well as type 3 collagen. Okay. And the genetic predisposition is there also. So they can ask you a question over this, whether the genetic predisposition is present or not. You will answer yes. Okay. Any doubt on this page?
Yeah, I typed a question for you.
Yeah. Ask.
I asked a question, I typed it. I said, if you have a cut on your hand, is there 100% regeneration?
If
you have a cut on your hand,
exactly.
regeneration is 100%.
Well, it depends. If the stem cells are removed, where the stem cells are found in the skin, the basal cell layer, right? If the if the cut is deep enough to remove the basal cell layer of the skin also, then the scar formation will occur. Okay, but if the injury is kind of superficial, do not involve the basal cell layer, then the complete regeneration will occur. Okay.
Okay, thanks.
So it depends if the stem cells are lost or not. And again, a case of ARDS, as I've already mentioned, in case of ARDS or the pneumonia, okay, if the type 2 pneumocytes are lost, which are present in the basement membrane of these, of this alveoli, so if they are lost, then the scar formation will occur, then the fibrosis will occur. If the basement membrane is impacted, if the type 2 pneumocytes are impacted, then in that case, complete regeneration will occur because the stem cells are there, right? And the same case with the hand. If the basal cell layer are removed, in case of a deep cut, then you will get the fibrosis. If the superficial injuries are there, then you will get the complete regeneration. And remember a case of scalded skin syndrome, Staphylococcus aureus scalded skin syndrome. It affects only the superficial layer of the skin, not the basal cell layers, right? And as a result, after the infection is over, the patient will get the complete regeneration of the skin. No scar mark would be left. I will tell you this in the later section also in the derma. The patient will have no mark, no scar because of a complete regeneration, because the basal cell layers are intact. Okay. Then we will discuss the neoplasia. Okay. Okay, so what is a neoplasia and neoplastic growth progression or neoplastic progression? It is basically uncontrolled and most importantly, monoclonal proliferation of cells. Only one type of cell undergo this pathology, the mutation, and it's start dividing indefinitely, forming a multiple type of similar same cell, exactly same cells. Okay, so it is a monoclonal proliferation of the cells. Very much important to know. Not a multiple type, but a monoclonal, right? For example, like in case of an infection, you will get the proliferation of lymphocytes. Remember, you will get a very high number of lymphocytes, but all these lymphocytes are polyclonal, different types. Okay, if a single type of lymphocyte start multiplying, then it can lead to the leukemia or the lymphoma. Okay, so the neoplasias or the cancer are always monoclonal type, single type of cell. Okay, and any type of tumor has two components. One is the cellular component, and second is the supporting stroma. The cellular component contains of the neoplastic cells, and the supporting stromas, they contain the connective tissue and the blood vessels. Why blood vessels? Because your cell required the nutrients and the oxygen for its development, right? So blood vessels would be there, and that's why in every kind of cancer, the blood vessel formation or the angiogenesis will occur. And the one way to treat the cancer is to give patient anti-angiogenic drug, which includes the bevacizumab, if you guys remember the name, anti-VEGF drug. Okay, so first initially, let's suppose that there was a normal tissue, okay, and every cell, as you can see, if you zoom in here, every cell has a polarity, either the basal polarity or the apical polarity. Okay, every cell is very kind of organized way, okay, as you can see. But now what happens is the dysplasia will occur. A certain number of a certain cell get mutated and it start dividing, okay, or the stress is kind of the stress was kind of very different, and that can lead to the metaplasia or the dysplasia of the cells. And in case of dysplasia, what you will get is the loss of apical polarity or the basal polarity. As you can see here in this diagram, some nuclei are upward, some nuclei are downward, you know, some nuclei are upward. Uh, the shape of every cell is kind of very different, as you can see. Some cells are big, some cells are small, right? Some cells are rectangular and something like that. Okay, so the the cell polarity is lost, uniformity of the shape and size is lost. Okay, the NC ratio of the cell is increased. Now these are the features of the dysplasia, and the most important thing to know that it is still reversible. If the change in stress or the stress is removed, then the cells can go back to normal, the first stage also, which is a normal tissue. But if the stress is persisted, then what you will get is the irreversible damage, and now it will become the carcinoma in situ. And in situ means it is localized to that certain tissue only. Okay, as you can still see here, this was the basement membrane, and the basement membrane is still intacted. So as long as the basement membrane is intacted, the cancer is not metastasized, and that means the cancer is the carcinoma in situ. Okay, very much important to know. Then comes the invasive carcinoma. When the basement membrane is invaded by the cancerous cells, the cancerous cells can now move to the blood vessels also and can become metastasized. So the fourth step is the invasive carcinoma formation. Okay, and how the invasive carcinoma formation occur? One is the inactivation of the E-cadherins. You will study that later in the MSK sections, that certain proteins are there, which keeps the cell put together. Okay, and one of them is the E-cadherin. And once the E-cadherin is lost, the cell can go or move freely inside the tissue. Okay, and then the cell will attach to the basement membrane. After attaching to the basement membrane, the tumor cell will release the metalloproteinases. And remember the function of metalloproteinases, they will degrade the collagen. Okay, and after degrading the collagen, the cells can easily cross the basement membrane. And once the cell crosses the basement membrane, they can gain access to the lymphatics or to the blood vessels, and as a result, the metastasis will occur. Now, as you can see here in this case also, this is a normal tissue. Okay, looks like a skin. As you can see, these are the keratinocytes. Okay, it must be the stratified or the keratinides or the sorry, this is a non-keratinized stratified squamous epithelium. As you can see, the squamous cells, Okay, these are the basal cells, as you can see, which are the stem cells. The mutation in one kind of these cells will happen, and as a result, as you can see, the cells are started dividing indefinitely. Okay, and as you can see also, the nuclei are kind of too much. The NC ratio is increased in these cells, as you can see, right? NC ratio is increased. Then the moderate dysplasia occur. As you can see, the cells will start proliferating too much, that they're going upward in the apical surface also, as you can see, and the growth has become very kind of dysplastic. The basal polarity is lost everywhere, as you can see, right? And finally the severe dysplasia occur. Okay, the NC ratio is too much. As you can see, this is a complete cell, and in this complete cell the nucleus is kind of occupying every space inside the cell. So NC ratio is increased, the cell size is changed, the cell shape is changed, the polarity is lost. Cells, because they lost the E-cadherin, they are moving everywhere inside the tissue, right? And finally, they're kind of involving every area of the tissue, and this is known as the carcinoma in situ. Okay, the basement membrane is still intact in this case, and once the basement membrane is invaded by the cancer cells, they will become the metastatic cancers. So any doubt on this page?
No.
Then you need to know about the nomenclature of the tumors. Okay, so one is the carcinoma, and second, is the sarcoma. The carcinoma implies the epithelial origin. Whenever a cancer cell, whenever the tumor involves the epithelial cells, for like a squamous cell carcinoma, for example, the squamous cells are the epithelial cells, and that's why they are the carcinomas. And the sarcomas, they denote the mesenchymal origin. That means every cell which is derived from the mesenchymal cells, okay, they are all known as the sarcomas. For example, the muscles, okay, they are known as the myosarcomas because they are of the mesenchymal origin. Okay, and both of these term means the malignancy. Then two type of tumors are there: the benign tumor and the malignant tumors. The benign tumors, they are kind of very well differentiated, very well demarcated. Very well differentiated means you can easily locate the origin of these tumors. Okay, because these tumors, the every cell in the tumor will resembles the origin of the cell. Okay, every cell in this tumor will resemble the origin of the cell, the original cell, and that's why they are very well demarcated. Okay, very well differentiated also. They have very low mitotic activity, which means they're very slow progressing tumors. Okay, there won't be any metastasis because they're benign, of course. They cannot invade the basement membrane. There won't be any necrosis. Okay, because the cells are kind of multiplying in a very slowly manner. Okay, not a very faster way, so that no necrosis will happen. The nutrients are kind of enough for every cell, so no necrosis. Okay, then comes the malignant cells, and they are very poorly differentiated, which means that one cell is kind of very much different from the origin of the cell, from the original cell, so you cannot exactly locate the origin of the tumor. Okay, very much important to know. They are poorly differentiated. They have this erratic or irregular growth. They have this local invasion. Okay, they invade the basement membrane and ultimately can go to the metastasis. Okay, and all of these cells have a decreased apoptosis, which is one way of the cell to living, right? Because they increase the BCL2 in them and decrease the BCLX or BAX. Sorry, BIM and BAX, and they will increase the BCLX and BCL2 so that they will become resistant of the apoptosis. Okay, then two terms important. One is the hamartoma, second is the choristoma. The hamartoma is means disorganized overgrowth of a certain tissue in their native location. Okay, so whenever a benign whenever a disorganized tissue, a benign tissue is formed inside their native location. Okay, for example, in the GIT or in the lungs, if their tissue will become very much disorganized, then they will form the hamartoma. Okay, and if they ask you what layers this hamartoma contain, so it will contain every layer that organ have. Okay, like in case of a lung, if the hamartoma is formed inside the lung, then they will contain the cartilage, they will contain the columnar epithelium. Okay, and in case of GIT, they will contain the scripts, They will contain the epithelial cell, the columnar epithelial cell. They will contain the stromal tissue also. So basically a disorganized growth in the normal area, right? Then comes the choristoma, in which a normal tissue is formed in a foreign location. Okay, for example, a Meckel's diverticulum that you know, in which, in case of a Meckel's diverticulum, sometimes what happened, the gastric tissues are found in the in this Meckel's diverticulum. So this is an example of choristoma. So know these terms, the hamartoma and the choristoma, very important. Okay. Then the examples of different tumors. Okay. In case of a benign tumor, they always have this name oma after them. Okay. And in case of a malignant tumors, they have either the name sarcoma or they have this name carcinoma after their name. Okay. So in case of an epithelial tumor, which is benign, it could be adenoma, it could be a papilloma. In case of a malignant tumor, it could be adenocarcinoma or papillary carcinoma. For the mesenchymal origin, for the blood cells, because the cells are already present in the blood. Okay, so they are already metastasized. So every blood cell tumor is gonna be a malignant tumor like leukemia and lymphoma, because cells are already in the blood, right? Already everywhere inside your body. Then the blood vessels tumor, if it is benign, it is hemangioma. If it is malignant, it is angiosarcoma. Similarly, smooth muscles, leiomyoma and leiomyosarcoma. The striated muscles, the rhabdomyoma, rhabdomyosarcoma. Connective tissue, fibroma, fibrosarcoma, and similarly other names. Then you need to know about the tumor grade and the tumor stage, and you need to know that tumor stage has, the tumor stage holds more prognostic value than the tumor grade. Very much important to know. The tumor stage holds more prognostic value, more importance than the tumor grading. Okay. So you need to know about the two terms, which is a differentiation, degree to which a tumor cell resembles to which origin cell. Okay. Degree to which a tumor cell resembles the origin of the cell. Okay. Very well differentiated tumors can be easily, you can easily locate their origin, while the poorly differentiated tumors, you cannot locate their origin because they do not resemble the origin cells, right? Then the anaplasia is kind of a tumor which is, completely lack the differentiation. Okay, you cannot even tell what kind of a cell it is. It has so much malignancy. So features of the anaplastic tumor would be the loss of polarity completely, complete disruption of the normal architecture would be there. You know that the cells in the anaplastic tumor, they are just focusing on the growth. They are not focusing on the function. Okay, while in case of a benign tumor, if you guys see, in case of a benign tumor, the cell are also focusing on the function as well as on the growth, right? They are maintaining their function, they are maintaining their growth. In case of an anaplastic tumor, the cell function is completely lost. They are just focusing on the growth, right? So they have the significant variation in the shape and the size. They have a very high NC ratio. They have this hyperchromatic chromatin, which is kind of very deep staining. Okay. They have this abundant mitotic figures. You can even see the giant cells in the anaplastic tumor, because I told you that anaplastic tumor do not resemble any kind of cell. They can form any kind of cell, right? So they have this giant cell as well as the multinucleate tumor cells. And this is a hallmark feature of a anaplastic tumor. Whenever the question is from describe any kind of a tumor which is having a giant cell and the multinucleate cells, then most probably describe you a anaplastic tumor. Okay, except for the giant cell carcinoma, of course, that you will study in the bone tumor section, because they are actually a tumor of giant cells. Okay, but if it is a epithelial tumor and the epithelial tumor you are seeing giant cell and multinucleate cells, that means it is a anaplastic tumor. Very much important to know the facts about the anaplastic tumor. Okay. And one more thing, the nucleolus, like I told you, they have very large nucleolus. Why nucleolus? Because in the nucleolus, you form the rRNA, and rRNA are required for the protein synthesis, right? So nucleolus also very much large. Then the grading is totally depend on how the tumor or the cancer resembles the origination. Okay. If the tumor has a very high differentiation, very well differentiated, then it has very low grade. If the tumor has very poor differentiation, that means it is very high grade. Okay. It is also dependent upon the mitotic activity. If the mitotic activity is too much, then the grade is very high. If the mitotic activity is very low or very less, then the grade is low. Okay, so a low grade means very good chances of recovery, very good prognosis, and a very high grade means a very bad prognosis. Okay, but the stage always holds more prognostic value than the grade. Even then the grade is so much high for a certain tumor, if the stage is low, then the tumor is still have a very high prognostic value, sorry, a very high prognosis. Okay, or the high chances of recovery. But if the grade is, let us suppose, very much low, if the tumor is very well differentiated, but the stage is so much high, that means the that means a very few chances of the recovery, or very uh, low prognosis. Like, so stage always holds more prognostic value than the grade. Okay, and for the stage you need to do three things. One is the tumor size, second is the involvement of the lymph nodes, and third is the metastasis. So like I told you, when the certain when a certain cell become mutated, it will start growing, it will start multiplicating, and then it will and then the tumor will increase in size. Let us suppose a tumor was first just give me a notation. Okay, let us suppose that the tumor was first of this size. Okay, then the tumor will become of this size, then the tumor will grow and become of this size, and finally it will become the carcinoma in situ. Okay, so the size of tumor, it is done by the T. Okay, then finally what happens, the tumor will invade the basement membrane. Okay, the basement membrane invasion will occur, and ultimately they will affect they will include the lymph nodes. Okay, so the involvement of lymph node is there or not, it would be determined by the N type, the N staging. And finally, after the involvement of this lymph nodes, if other lymph nodes are involved also, then it could be done by the M, which we determine for the metastasis. So tumor size, lymph node involvement, and the metastasis is there or not, they will determine the TNM staging. And like I told you, if the tumor is very well differentiated, but it has very high stage, which means the involvement of lymph nodes are there and the involvement of metastasis is there, that means the tumor has very poor prognosis. And if the tumor has very high grade, which means the tumor is kind of anaplastic type, or the tumor is very poorly differentiated, but it has very low stage, which means no lymph node involvement, no metastasis is there, that means that the patient has very high prognosis, it could be easily cured. Okay, so stage always has more prognostic value than the grade. And even in this TNM, the N and M are most important. Okay, size is always doesn't matter. If the tumor has very large size but no blood vessels or lymph nodes are affected, that means the tumor can still be excised from the body and the patient has very high prognosis. So N and M are, node and metastasis, are very much important for the staging. Any doubts so far in this page?
What are mitotic figures?
Mitotic figures are the cells which are dividing. Actually, not every cell are dividing, right? There are the cells which are the cell cycle, if you guys remember, the G0 phase, G1 phase, S phase, G2 phase, and then M phase. So those cells which are in the M phase, they're actually dividing, right? And these are the mitotic figures, in which you will see the chromatin, you will see the chromosomes, you will see the what you call them, forgetting the name, the microtubules, the centrosomes, right? Remember, if you guys, let me check the name again. The mitotic spindles and the centrioles in the cells, if you are seeing that, this means these are the mitotic cells, which are the cells in the M phase that are actually dividing, right? These are the mitotic cells, or the mitotic figures. Okay.
So how do we recognize them while seeing the slide?
You will see the centrioles, like I told you. You will see the mitotic spindles in them. If the mitotic spindles are present, if the centrioles are present, that means these are the mitotic figures. Don't worry, you don't need to identify them in the in the histology for step 1. They won't ask you for that because it is kind of very high stuff, to recognize them. So not at our stage. Okay, just need to know that these are the cells which are in the M phase, which are actually dividing. Okay, step 1 won't ask you to recognize these cells. Don't worry about that. Yeah.
Okay. Thank you.
I think it's your network issue. Okay, so someone is asking about the spindles. Spindles, remember when we talked about the mitosis, this is a cell. These are the two polar ends, one centriole and the second centriole. And in between there are the chromosomes, right? These are aligned along the metaphasic plate, and right. And then this spindle formation will occur, which are the microtubules. Okay, these are the spindles, which are the microtubules, and they will guide the movement of the chromosomes to other ends. So the chromosomes, which are this is the metaphasic plate. Okay, so the chromosomes which are at this side of the metaphasic plate, they will go at this direction to the lower side, or that L side or the U side. Okay, so the chromosomes which are at the L side of this metaphasic plate, they will go to this kind of centriole. Okay, and it is guided by the spindles, which are the microtubules, the railroads. Okay, so these are the spindles which guide the movement of the of these chromosomes inside the cells. These are the microtubules. Please refer to the biochemistry section, the microtubule thing. Okay, are we good?
Yes, sir.
Okay, so any other doubt?
No.
Okay, then the hallmarks of the cancer, like I told you, one of the most important feature is the monoclonal proliferation, right? And yeah, the DNA is caused by, of course, the cancer is caused by the DNA mutations. Okay, that affects fundamental cellular processes like the growth, the DNA repair, and the survival, of course, right? So first hallmark feature is the growth signal self-sufficiency. These cells, the tumor cells, they will develop, some kind of a growth factors itself. Either they will mutate their growth factor receptors, or they will mutate their transcription factors, so that no more growth factors are required for their growth. Okay, they become self-sufficient for the growth. Like I told, if you guys remember the pathway, then first the growth factor will come and it will stimulate the receptors. Then the receptors will activate the transcription factors, and then they will cause the cell growth. Now tumor cells, they will do what? That they will mutate their growth factor receptors, and as a result, the growth factor receptors will be keep on activating. And if they become activate, then they will activate the transcription factors, and then they will cause the growth, right? So the growth signal self-sufficiency is one of the hallmark feature of the cancer. Okay, then in case of proto-oncogenes, in case of increased growth factors, you will get the autocrine loop. For example, in case of a platelet-derived growth factor cancers, they will have this autocrine loop in which the platelet-derived growth factor keep on binding with the growth factor receptor, and as a result, the cell will divide indefinitely, right? Then comes the growth factor receptors. If the growth factor receptors become mutated, like in case of a HER2 new breast cancer, then they do not require the proto-oncogenes for function, right? They do not require the growth factors. Okay, they will keep on activating by themselves, and they finally activate the transcription factors. Third one are the signal molecules. If the RAS become mutated, then it will activate the downstream proteins and they will cause a cell growth. If the transcription factors become mutated, then they will keep on activating the genes by binding to the effector site of the gene. It will activate the gene, form the protein, divide the cell. Okay. Then in cell cycle regulators, like I told you, you need the cyclins and the cyclin dependent kinases to move from one stage of the cell cycle to the other stage of cell cycle. If the cyclins or the cyclin dependent kinases become mutated, then no tumor suppressor gene can stop them, and as a result, what you will get is the indefinite cell cycle. And and the indefinite growth of the cell. So the first thing is the growth signal self-sufficiency. Then comes the anti-growth signal insensitivity, which are the tumor suppressor genes. If the tumor suppressor proteins or tumor suppressor genes are lost, then what's gonna happen? The cell will become cancerous, right? And the similar thing is the loss of E-cadherin. Like I told you that E-cadherin are basically the proteins which keeps the different cells very close to each other, right? And if the E-cadherin is lost, then the cells can move freely and they can divide indefinitely, right? So one of the thing. Next is the evasion of apoptosis. Okay, so all the cancerous cells will upregulate their BCL2, BCLX. They will downregulate the BAX and the BID. That you guys remember, they will upregulate the anti-apoptotic proteins and they will downregulate the pro-apoptotic proteins so that the apoptosis cannot be happened. Like the example of follicular B-cell lymphoma. Okay, and they will have this high BCL2 activity in them. Okay. Third thing is the limitless replicative potential. Like I told you already about the telomerase enzyme and the telomere sequence. With every division, the telomere sequence will keep on shortening. Okay, the telomerase will try to repeat it, will try to repair it, but ultimately what's going to happen after certain number of divisions, the telomere sequence would be lost and the cell will undergo the apoptosis. But in case of the cancer cells, they have this very high activity of telomerase, and as a result, the telomere sequence would be keep on maintaining, and as a result, it won't be shortened, and as a result, the cell will get the indefinite growth and indefinite multiplication. Then the angiogenesis, because every cell requires the proteins, the oxygen, and the other nutrients for their function. So the blood vessel formation is a hallmark feature of the cancer itself again. Okay, and you require the vascular endothelial growth factors for that, right? If you guys know, and that's why you give the patient bevacizumab, which is an anti-VEGF drug or the molecular antibody to inhibit the angiogenesis. Okay, and because of the angiogenesis, because newly formed blood vessels are kind of very leaky, okay, you will get the hemorrhage in case of this tumor also, right? Third thing is the tissue invasion. How the tissue invasion occurs? First is the loss of E-cadherin so that the cell can move. Then the cells will attach to the basement membrane, and that could be done by the laminin and the fibronectin. Very important. The laminin and fibronectin are two proteins which are found in the basement membrane, and the cells will attach to the basement membrane via these proteins. Step one will ask you the name of these proteins. Very important. And once the cells, once the tumor cells are attached to the basement membrane using these proteins, they can cause the release of metalloproteases so that they can invade the basement membrane, right? Third thing is the metastasis. So what's going to happen after the invasion of the basement membrane? The cells will invade the blood vessels, and using the blood vessels, they will go to different tissues, right? And wherever they lodge, wherever they forms the homing, very important to know the homing process. Wherever the cancer cells lodge, okay, they will cause the homing there. They will form their homes there, and that's why the process homing. Okay, they will form their homes there, and they will replicate there. They will divide there, and they will form the location of cancer in that tissue also. This is a metastasis. Okay, some cancers also show the specific organ tropism. For example, in case of a lung cancer, they most commonly metastasize to the adrenals. They will form the homing in the adrenals. So all the cancer drugs, which are destroying the metastasis of the cancers, they are destroying the homing process of the cancer, right? Very much important. Then comes the Warburg effect. Okay, because even though the all the nutrients and all the oxygen is available for the cancerous cells, they still instead of the oxidative phosphorylasis, they will use the non-oxidative phosphorylative way for the glucose use. Okay, so they will form the lactose, the lactic acid. Instead of the oxidative phosphorylation, they will form the lactic acid. Even though the oxygen is available, every nutrient is available, they will form the lactic acidosis instead of the oxidative phosphorylation after the glycolysis. Then comes the immune invasion, because cancer, to be a perfect cancer, it should be able to evade the immune response. Okay, it should be able to pass through the immune checkpoints, right? So one way is to decrease the MHC, because MHC is recognized by the CD8 cells. So if the MHC is lost, then the CD8 cells or the cytotoxic T cells cannot recognize the tumor cells, right? This is the one way. Second is the secretion of the anti-inflammatory cytokines, which are the TGF beta. If the anti-inflammatory cytokines are released, then the cells become inactive against the tumor cells. Okay. Third is the immune checkpoint regulators, and we are going to discuss these immune checkpoint later. Immune checkpoints here in this page. In this, you need to know about these PDL1s. Okay. Okay, so you need to know about the PDL1s, which are the programmed death receptors, okay, and the ligands. And second is the CTLA4. Very much important to know about these two functions. Okay, so at the immune checkpoints, they present the cytotoxic T cells, okay, which check the MHC proteins of every cell, right, to identify the tumor or the virally infected cells. Now, what does a tumor cells do at this point? That they will upregulate their PDL1, okay, which are the they will activate the program death receptors on the T cells. And once the program death receptor activated, the T cells will be exhausted, and as a result, it can no longer be functionable. Okay, so the tumor cells have this ligand, which is the PDL1 or the PDL2, okay, or the program death receptor ligand 1, 2, and the receptors, the program death cell receptors, are found on the cytotoxic T cells. Okay, once the tumor cells which have these ligands, they interact with the PD1 receptors, the T cells will be exhausted, and as a result, the immunity against these cells will be suppressed. So this is the one way of passing the immune checkpoints. The other way is the CTLA4. Okay, so what's gonna happen if the CTLA4 has a very high affinity for the B7 than the CD28? Remember the function of CD28? It binds to the B7 on the antigen presenting cell, and this is a second stimulated signal in the activation of T cells, right? If the CTLA4 is binded to the B7 instead of CD28, and CTLA4 has a very high affinity of B7 than CD28, then ultimately what's gonna happen? The exhaustion of the T cells, right? So two things are happening. One is the interaction between the program death receptor 1 and the program death receptor ligand. And second is the interaction of the CTLA4 on the T cells with the B7 of the antigen presenting cells. And as a result, the co-stimulated signal would be lost. So cell can never be activated. Okay. So in the first case, in the interaction between the PD1 and the PDL1, there will be the exhaustion of the activated cell. In case of the CTLA4 interaction with the B7, there won't be any activation of the cell. And that's why you need to give the patient drugs against these PD receptors, which is the pembrolizumab. Very much important to know. The pembrolizumab is basically a drug, a monoclonal antibody against the program death receptor on the T cells. Okay. Very much important to know. And second is the ipilimumab, which is a monoclonal antibody against the CTLA4 receptors on the T cell. So pembrolizumab, very much important. It is the most important thing here. The function of pembrolizumab is to inhibit the PD1 receptor so that the PD1 ligands can never interact with the PD1 receptors and the tumor cells can never pass through the checkpoints. And seconds are the antibodies, the ipilimumab, which is against the CTLA4, so that the CTLA4 cannot interact with the B7 and this co-stimulated signal could be generated. So this is the immune checkpoint. Any doubt on it?
No.
And you also need to know that how this T cells, apart from this, how this antigen presenting cells actually recognize the tumor cells. Why this CTLA4 and B7 interaction happening as first phase. You need to know about that too, because you guys know that the mutations that cause this cancerous growth. These are the same mutations which form some kind of a new proteins on the tumor cells. Okay, so the mutations that are causing the cancer, these mutations also forming some new proteins on these tumor cells, and these new proteins are a kind of detected by the antigen presenting cells. And once these new proteins are detected by the antigen presenting cells, they will display them to the T cells. Okay, and and after the presentation, the T cell could be activated and they can kill the tumor infected cells. This is very important to know. Genetic mutations that causing the oncogenesis also creates a unique proteins that are not found normally on the healthy cells. And this is a pathway by which the CD8 cells can easily recognize these tumor cells, right? Or the antigen presenting cells can present a new antigen to the CD4 cells or the CD8 cells so that the tumor cells can be recognized. Okay, so you need to give the antibody against the PD1 and the CTLA4 to prevent the tumor cells from passing the immune checkpoints. And then you need to know the cancer epidemiology. Okay, and you need to know that the skin cancer is overall the most common cancer. Okay, apart from the skin cancer, in case of men, the prostate cancer is the most common cancer. Okay, lung cancer second most common, and the colon cancer third most common. In case of a cancer mortality, the most common deaths are occurred by the lung cancer. Second most common cause of death is the prostate cancer, and third most common cause is the colon cancer. In case of women, the most common is the breast cancer, second most common lung and colon cancer, just like the men. Okay, for the death, just like the men, the lung cancer is the most common cause of death. Then comes the breast cancer, then comes the colon cancer. In case of children, leukemia is the most common cancer. Okay, then comes the CNS cancers, and finally the neuroblastoma, the three most common cancer in the children, and death occur in the same sequence: leukemia, CNS, and the neuroblastoma. And then you need to know overall cause of death apart from the cancer, because cancer is not the most common cause of death, but it is the cardiovascular diseases. The CVS diseases are the most common cause of death in the United States in both male and the female. So if the question stem gives you a certain history of a patient on or a certain scenario, I got a question over it where there was a patient who is about to die, and he just give all her property to the charity to treating the most common cause of death in the United States, and then they will give you certain options like breast cancer, lung cancer, or the CVS diseases. So you need to choose the CVS diseases as the most common cause of death. So do not get misled. The most common cause of death in cancer is the lung cancer, prostate, and the colon cancer, but the most common cause of death overall is the cardiovascular disease. Okay. And you also need to know that the lung cancer incidence has dramatically reduced in case of men's, but it has not changed in case of women's. Okay, and heart disease is the first most common cause of death. And then step one can also ask you that what kind of cancer actually generate a highest immune response. So it would be a cancer which is caused by the viruses. For example, the Epstein-Barr virus or the human papilloma virus, because two things are going to happen. One is the viral infected cell, and second is the tumor cell itself, right? So immune response generated against two cells. One is the virus, and second is the tumor cells, and that's why the highest immune response is generated in the virus against the tumors which are caused by the viruses. Very important. And so, any doubt so far?
No, thank you.
Yeah, so I think we should take a short break here. Then we will discuss a further chapter, okay?
Okay, thank
Okay.
you.
Just a second. Yeah. So, yeah, because liver has multiple blood vessels. So whenever a tumor reach here, it can launch at multiple directions at multiple areas. So what you will see are the multiple foci of tumors inside the liver whenever it is a metastatic tumor. Whenever it is a primary liver tumor, there is always going to be a solitary lesion in the CT or MRI. But in case of a metastasis, it's always going to be a multiple foci of tumor, right? And the most common location to metastasize at the liver is your colon. Okay, then comes the stomach, then comes the pancreatic tumor. Okay, colon, stomach, and then pancreas. And how a tumor can reach to the liver? It is by the portal blood vessels. Very important to know, because portal circulation, it ultimately gonna end in the liver. So any tumor which is in the GI tract, it will reach to the liver by the portal circulation and will lodge here at multiple areas, right? Very much important to know. Then comes the bone, and the most common tumors which metastasize to the bone are the prostate and the breast, then the kidney, thyroid, and lung. So prostate, breast, most common, then kidney, thyroid, and lung. And certain tumors which lodge in the bone, some of them uh, are the blastic tumors, osteoblastic type, and some of them are the osteoclastic type. Okay, in the osteoblastic lesions, you will have the formation of bone. In the osteoclastic lesions, you will have the degradation of the bone. Okay, for the prostate and the breast cancer, they form the osteoblastic type of metastasis, which means you will get the bone growth instead of the bone resorption. Okay, while the tumor from the lungs, from the kidney, they are the osteoclastic type. So what you will see are the bone degradation in that case. The lytic lesions would be seen. Okay, and the small cell lung cancer, the breast cancer, and the prostate cancer, these are the example of blastic type tumor. While the other lung cancers, other non-small cell lung cancer like adenocarcinoma of the lung, they are the lytic type tumors. The thyroid tumor, the kidney tumor, they are the lytic type of bone metastasis. Okay, and you also need to know that bone metastasis is more common than the primary bone tumor itself. Okay, and one of the primary bone tumor is the multiple myeloma, which is a tumor of your bone marrow, right? You have the plasma cells tumor there. So as you can see, this is a tumor. Okay, in case of a liver, you have this multiple foci, right? And this is a tumor. This is a primary tumor, I must say, because it is a solitary lesion. You cannot find multiple lesions here, but as you can see here, there are multiple lesions present. Like in case of a liver, this is a liver, a gross specimen of the liver. You are having this multiple foci of the tumors of the metastasis, right? So it is a metastatic tumor, not a primary tumor. As you can see in the bone, there are these lytic lesions. So these are the lytic type of metastasis. And as you can see here in the gross specimen, you have this bone formation here, right? So it is a so it is a osteoblastic type of metastasis. Two type of metastasis to the bone: osteoclastic, which destroy the bone, and osteoblastic, which forms the bone. And you can see here all these foci that you are seeing, these are the foci of tumor that are metastatic to the bone. Okay, and the step one will ask you how the prostate cancer reaches the bone. It is by the vertebral venous plexus. Very important to know. The the prostate cancer will reach to the bone by the vertebral venous plexus, also known as the Bateson's plexus. Okay, very much important to know. And then the step one will also ask you if a tumor is metastasizing by the lymph node pathway, by the lymphatics. So it will cause a lymphadenopathy, of course, because it will lodge in the lymph nodes, and in the lymph nodes, it will cause the lymphadenopathy. So step one will ask you what are the hallmark features of lymphadenopathy in malignancy. Okay. So in the biopsy, the most important thing is the monoclonality, because in the lymph nodes, you have these lymphocytes, right? And lymphocytes, whenever an infection present, they will start replicating. They will reach to even lakhs. But that doesn't mean that the patient is having lymphoma, because all of these lymphocytes are polyclonal type, right? But if you find only a monoclonal type of cell in the lymph nodes, that means it is a tumor, right? The first thing. Second, what type of lymphadenopathy you will get in case of malignancy? So the lymph nodes will be non-tender, very much important, because if the lymph nodes are due to a infectious cause, then they most commonly be a tender type of lymph nodes. You will have pain on touching, right? It would be a very hard nodule, while in case of an infection, it would be a soft type of nodule. Okay, and with the time, the lymph node will increase in the size. The lymphadenopathy will increase in the size. So it would be a progressive lymphadenopathy. It will increase in size. And you will also get the systemic features like weight loss and night sweats in case of it. Okay. And the enlargement of a supraclavicular lymph nodes, like I already mentioned in the immuno section, if the supraclavicular lymphadenopathy is present, then it is a very specific thing for the cancer. Okay, very much important because you won't get the supraclavicular lymphadenopathy in case of infections. No infections can reach to the supraclavicular lymph nodes. It's only the tumors like from the chest, from the abdomen. Yeah, Burkhouse lymph node, exactly. From the chest, from the abdomen, that can reach to here, right? So whenever a question stem describes a supraclavicular lymphadenopathy, it always gonna be a case of your malignancy. And what are the other features? Firm, non-tender, mobile type. It could be increasing in the size and the systemic features. These are the hallmark features of lymphadenopathy in malignancy. Okay, so any doubts so far in this page?
No, thank you.
Okay, then you need to know what different proto-oncogenes can cause different cancers, what tumor suppressor gene mutation can cause what type of cancers. It is a pretty huge table, but you need to know every single name, every single gene in it. Okay, so let's discuss the first the oncogenes. Okay, what are different oncogenes can cause the different type of cancer. So easy way to remember this table is by knowing the pathway of the growth factor signal and the activation of the cell and the cell growth, right? So you need to know about the tyrosine kinase pathway. What gonna happen whenever a certain growth factor come for a cell to induce the cell growth? For example, let it be a platelet derived growth factor, let it be a epidermal growth factor. What gonna happen? They will bind to the tyrosine kinase receptor. It is a kind of receptor which has a tyrosine residues in it and an enzyme tyrosine kinase. Whenever a growth receptor, whenever a growth factor bind to this receptor, the receptor dimerization occur. Initially, the receptor would be like this. Let us suppose this is a cell, okay, and this is a receptor inside the cell. This is a tyrosine kinase. This is a receptor which has an intrinsic tyrosine kinase activity. Okay, it has some tyrosine residues in it, right? And the tyrosine kinase activity. So whenever a growth factor come and bind to this receptor, the receptor dimerization will occur. The receptors will attach and will be seen like this. Okay. So after the receptor dimerization, this enzyme, the tyrosine kinase, will be activated. Okay. And after the activation of this tyrosine kinase enzyme, it will cause the phosphorylation of the tyrosine residues in this receptor. Okay, and as a result, what gonna happen? The phosphorylation of the tyrosine receptor of this residues in the receptor. After the phosphorylation, the other proteins in this pathway will bind to this phosphorylated tyrosine. Okay, and after binding to the phosphorylated tyrosine, they will get phosphorylated and they will get activated. One of them is the RAS. Okay, RAS, after binding to the tyrosinase, after binding to this phosphorylated tyrosine, it will take the phosphate group, and from the GDP RAS, it will convert it to the GTP RAS. GTP, like the ATP, if you guys remember from the biochemistry section. Okay, it provides the energy to the RAS. So GTP RAS is the activated form. Okay, once the GTP RAS is activated, it will activate the further downstream products like the the BRAF. Okay, and finally this BRAF will activate the DNA binding proteins and the transcription factors that you guys know. Okay, some of them are the C-Jun, C-Phos. We have discussed that in the biochemistry section. The C-MYC, N-MYC, MYC-L1 or L-MYC, and the cyclin D1s, which are the cell cycle regulators. All of them will get activated, and after they get activated, the cell growth will occur. So any kind of mutation, if happens in this path, it can lead to the cancer. Okay, and we will discuss every mutation one by one, which is mentioned in that table before. Okay. So for the platelet-derived growth factors, you can get the astrocytoma and the glioblastoma. So if an autocrine loop is created for this platelet-derived growth factor, it will cause the astrocytoma and the glioblastoma. First year, I think, didn't mention it. I don't know about 2021 edition, but 2020 edition do not mention it. But the PDGF actually can cause the astrocytoma and the glioblastoma, right? Then the tyrosine kinase receptors of different tissues, like the ELK receptor. ELK receptor is a receptor which has an intrinsic tyrosine kinase activity. Okay, and this receptor is found in your lungs. Okay, if the mutation in this receptor happened, then the receptor will become activated without the growth factor, and as a result, it will cause a further downstream signaling, and the ELK can cause the lung carcinoma. Very much important. No, ALK has L in its name. Okay, so L can cause the lung carcinoma, adenocarcinoma of lung, AL. Okay, it can cause the adenocarcinoma of lung. Then the HER2 cancer, which you already know, the ERB-B2 also known as. Okay, so HER2 or the ERB-B2, it can cause the breast cancer, and it is also responsible for the gastric cancer, right? Then comes the ERB-B1, which is the HER1 or the ERB-B1. It can cause the lung cancer. Okay, very much important. No, it can cause the lung cancer, adenocarcinoma of the lung. Okay, just hold on a second, guys. Okay, so yeah, we are back. The RB1 can cause the adenocarcinoma of the lung. Then comes the RAT. RAT is a RAT is again a receptor tyrosine kinase. Okay, if the mutation in the RAT happen, it can lead to the MAN2A, MAN2B syndrome. If you guys remember, what cancer includes in the MAN2A syndrome? Anyone?
Medullary thyroid carcinoma.
Okay, one is a papillary thyroid carcinoma. Second is the pheochromocytoma, if you guys remember. And third is the hyperplasia of the
Parathyroid.
Exactly. Please remember the fact in MAN2A, it is not the cancer of the parathyroid, it is a hyperplasia of the parathyroid. But in case of a MAN1, it is a tumor of the of this gland, the parathyroid gland. Okay. And then the MAN2B, which includes a papillary thyroid carcinoma and the pheochromocytoma and the mucosal cancers or the mucosal neuromas, if you guys remember. Okay. So these four receptors, the tyrosine kinase receptor, all of them has the activity of this tyrosine kinase. It will phosphorylate the tyrosine residues and activate the RAS. So you need to know the function of this RAS. The RAS which is binded with the GDP, it is the inactivated form of the RAS. Okay. After binding to the tyrosine, after binding to the phosphorylated tyrosine, it would become the GTP RAS. Okay, RAS with the GTP. It is the activated form. Now this RAS also has the GTPase activity, which means by the action of the GTPase enzyme, the RAS can be converted to its inactivated form. Okay, and this is the way by which the RAS is inhibited. If the GTPase become mutated, then this GTP RAS, the RAS with GTP, cannot be converted into the RAS with GTP. So it would be activated indefinitely, causing the cell growth, right? And if the RAS is activated, okay, and there's your FS mentioned about the KRAS, okay, it can cause the colon cancer, lung cancer, and the pancreatic cancer. Okay, if the GTPase is mutated, then the RAS with GTP will be indefinitely activated. It can lead to the colon cancer, lung cancer, and the pancreatic cancer. Okay, the adenocarcinoma. Then when the RAS is activated, it will further activate the downstream proteins. One of them is the BRAF. Okay, and BRAF mutation, if happens, it can lead to the activation of many other transcription factors, right? And it can lead to the melanoma, papillary thyroid carcinoma, and hairy cell leukemia. Very much important to know. BRAF mutation can lead to the melanoma, hairy cell leukemia, and the papillary thyroid carcinoma. Okay. Then comes the proteins which bind to the DNA, like your transcription factors. Okay, some of them are the c-Jun, c-Phos, like we have discussed in the biochem section. Other them are the c-Myc. If the mutation of the c-Myc happens, it can lead to the Burkitt's lymphoma. If you guys remember the translocation of the Burkitt's lymphoma, anyone?
814.
8 and 14. And on the 8th chromosome, it was the c-Myc oncogene, right? And it will be translocated with the gene on the chromosome number 14, which is a Ig heavy chain gene. Okay, and once it is translocated to the 14 at the place of Ig heavy chain gene, it would be transcribed in too much amount, and because it is a transcription factor, it can cause a cell growth. It can lead to the Burkitt's lymphoma. For the NMYC, it can lead to the neuroblastoma. Okay, and the LMYC or the MYC-L1, it can lead to the small cell lung cancer. Very much important. Elmic or McElvain can lead to the small cell lung cancer. Okay. Then similarly, you have the cyclin D1s. Okay, and these cyclins, they basically regulate the cell growth, like you already know. If they become mutated, then the cell can easily go into a cell cycle and reach to the M phase and can be divided. Then there are other type of receptors which do not have the intrinsic tyrosine kinase activity. But what happens when the growth factor bind to these receptors? It will activate the cytoplasmic tyrosine kinase. The tyrosine kinase which is present in the cytoplasm will be activated, and after that the downstream signaling pathway will be activated. So these are known as the non-receptor tyrosine kinase. One of them is the BCR-ABL gene fusion. One of them is formed by the BCR-ABL gene fusion, and you know it as a Philadelphia chromosome, right? It will form the chronic myeloid leukemia, okay, and the acute lymphoblastic leukemia. The chronic myeloid leukemia and acute lymphoblastic leukemia is formed by the non-receptor tyrosine kinase BCR-ABL fusion. Okay, and yeah, any other blood cancer that you guys remember? You know, the polycythemia vera, for example, or the megakaryocytes tumor. You know, they all involve the tyrosine kinase without the tyrosine. Sorry, the tyrosine receptor without the tyrosine kinase activity, or the non-receptor tyrosine kinase. Okay. You guys studied later in the endocrine section also. I will tell you about all the receptors, you know, the blood cell uses, okay, for the signaling, and the all receptors are the non-receptor tyrosine kinase, which means a receptor which do not has the intrinsic tyrosine kinase activity. So in case of a polycythemia vera or a megakaryocytosis, you will have the mutation in the non-receptor tyrosine kinase. Very much important to know. Okay. And I think I've covered everything. And JAK2, yeah, I forgot to tell you about the JAK2, which is itself not the receptor, but the tyrosine kinase. Okay, JAK2 is a tyrosine kinase, which is activated by the receptor itself. If that become mutated, it can lead to the chronic myeloproliferative diseases. It can lead to the chronic myeloproliferative diseases, the JAK2. Okay. So I think I've covered every single oncogene in this table. Yeah. Any gene remaining? I've covered, right?
Did you mention BCL2?
BCL2, it is not a tumor. Sorry, it is not a growth factor related pathway, but it has a separate pathway, right? The apoptotic pathway. Okay, so it is not a sorry, yeah, it is oncogene, of course. Yeah, I'm sorry about that. It is not in this pathway. So BCL2 is basically a anti-apoptotic gene. Okay, once it become activated, the apoptosis of cell cannot be happen right now, right? And if the apoptosis of cell cannot be happen, it can become the cancerous cells. For example, the follicular B cell lymphoma. In case of a follicular B cell lymphoma, what translocation happens? 14 and 18, right?
18.
Yeah.
Yeah,
18.
14. Yeah, 14 and 18. And on the 18th chromosome, it was the BCL2 gene. And on the 14th chromosome, it was the Ig heavy chain gene. So Ig heavy chain gene is replaced with the BCL2 gene, so that the BCL2 gene can be transcribed too much in the amount, and as a result, the BCL2 would be too much in the cell, and as a result, the cell will become resistant to the apoptosis. Okay, I think every oncogene is covered now.
Yes.
Yeah. Then comes the tumor suppressor genes, which are the gene which suppress your tumor, of course. And for every of them, you need to know about the nuts and two hit hypothesis. Like I've told you, the loss of heterozygosity. You guys remember in the biochemistry? Remember the loss of heterozygosity in the biochemistry I've told you about, the nuts and two hit hypothesis, that whenever a patient has this hereditary type of tumor, hereditary mutation, it will become the heterozygous for that mutation in the tumor suppressor gene. And if the second gene is knocked out, if the mutation in the second gene is happened, then this heterozygous patient will become the homozygous for the mutation, and now the patient can develop the cancers. So for every tumor suppressor gene, both genes must be knocked out before the tumor can happen. Okay, this is a nuts and two hit hypothesis. Okay, one is the APC gene, okay, which is a negative regulator of the Wnt pathway. Wnt pathway, you will study that later in the renal section, I think. Yeah, something like that, and it can lead to the colon cancers. Very much important to know the Wnt pathway, the APC. Remember the sequence, the APC, the KRAS, and the TP53 sequence. Remember, guys?
Yes.
The APC, yeah, with the APC gene, then the KRAS gene, and finally the TP53 gene. So APC is the tumor suppressor gene, and if it is knocked out, it can lead to the colon cancer. Okay, then comes the BRCA1 and the BRCA2 genes, and like I told you, they're involved in what kind of DNA repair? If anyone remember, homologous or non-homologous? Anyone? Homologous repairs. Okay, so BRCA1 and BRCA2 are involved in the homologous repair. So if the mutation in the BRCA1 and BRCA2 occurs, it can lead to the breast, ovarian, and the pancreatic cancers. Very much important. This breast, ovarian, and the pancreatic cancer. Then comes the CDK2NA, okay, which blocks the G1 to S phase. Okay, and if it is mutated, it can lead to the melanoma and the pancreatic cancer. Although I've never encountered any question on this thing, but you guys should remember it. CDK2NA. Then the DCC, you can remember it as a deleted in the colon cancer. Okay, so it can lead to the colon cancer. Okay, then the DPC4, which is a deleted in the pancreatic cancer, so it can lead to the pancreatic cancer. Then the MEN1, you guys already know that the MEN1 syndrome, the menin is mutated, and the menin is a tumor suppressor protein. But in case of a MEN2 and MEN2B syndrome, it was the proto-oncogene RET which is involved, right? So it can lead to the multiple endocrine neoplasia type 1. What tumors include in the multiple endocrine neoplasia type 1?
Pituitary, parathyroid, and
Pituitary,
Pancreas.
pituitary, pancreas, and the parathyroid
Parathyroid.
tumor.
Parathyroid.
Then comes the NF1 and NF2 that you study in the neurology section. Okay, the NF1 is codes for the neurofibromin. You must remember this. Okay, neurofibromin. Okay, and it can lead to neurofibromatosis type 1. Okay, the NF2 is codes for the Merlin. Okay, so neurofibromin and Merlin, you guys remember it like that. Neurofibromin and Merlin. So Merlin can cause the neurofibromatosis type 2. What tumors includes in the neurofibromatosis type 2, if anyone remember?
Bilateral vestibulocochlear nerve
Okay,
tumor.
yeah, and you will get the schwannomas. Yeah, you will get the cataracts. You will get the meningiomas. Remember, you will get the bilateral vestibular schwannomas. You will get the cataracts, and you will get the meningiomas. Then the P10 mutation, very much important to know. The cancers which can happen after the P10 mutations. These are the prostate, the breast, and the endometrial cancers. And you can remember it by the name as well. The P for the prostate, the T in the breast, and the EN for the endometrial cancers. Okay, so step 1 will give you a history of a complete family in which some of the family members having this breast cancer, some of the family members having the prostate cancers, and some of the family members having the endometrial cancers. And they will ask you what mutation it is, and so we'll answer the P10 mutations. Very much important to know. Then comes a retinoblastoma gene. Okay, and if the mutation happens in this, and you need to know function of this RB gene. Okay, the RB gene actually carries the elongation factors, if you guys remember. Okay, and it is a hypophosphorylated form which is activated. Okay, when the cyclins become activated, after combining with the cyclin dependent kinases, when the complex become activated, it will phosphorylate the RB gene. RB protein, and as a result, it will lose the elongation factor so that the cell can progress from the G1 to S phase, right? If the patient is having a hereditary RB gene mutation, that it can lead to the retinoblastoma and the onchosarcoma. Very much important to know. Only in case of a hereditary mutation, the patient can develop the retinoblastoma and the osteosarcoma. In case of a sporadic mutation, it can only lead to either the retinoblastoma or either the osteosarcoma. And one more thing, in case of a hereditary retinoblastoma mutation, the patient will develop the bilateral retinoblastoma in the eyes. In case of a sporadic tumor, it would be a unilateral retinoblastoma in the eye. Okay, very much important to know. Then the TP53, like the pathway, you guys remember the APC, the KRAS, and the TP53 pathway. It can lead to the colon cancer. Okay, it can lead to the Lee-Fromini syndrome, which includes a SBLA, SBLA, the sarcoma, the breast cancer, the leukemias, and the adrenal gland cancer. Okay, and you guys remember the function of this TP53. It is involved in the regulation of the apoptosis of the cell. Okay, if the cell has mutation, then it will call for the DNA repairing enzymes. If the DNA mutation is beyond repair, then it will call the pro-apoptotic proteins like BAX and BID, and they will cause the apoptosis of the cell. Okay, so it regulates the apoptosis. Then comes the TSC1 and TSC2, which codes for the hamartin and tuberlin, and they both can lead to the tuberous sclerosis. Very much important to know, tuberous sclerosis. If you guys want to remember the chromosome location, it is chromosome number 9 for TSC1 and chromosome number, I think, 16 for the TSC2, although you don't need to remember it. But just remember the proteins they code for, hamartin and the tuberlin proteins. Okay. And so that you will get the multiple hamartomas throughout the body. Like in the brain, you will get the CNS hamartoma. You will get the angiofibromas in the skin, hamartomas of the skin. You will get the rhabdomyoma, right? You will get the angiomyolipoma and other things. We will discuss that later in the neurology section also. So just wait for it. Then comes the von Hippel-Lindau, and this von Hippel-Lindau codes for a protein which inhibits the hypoxia inducible factors, which means the factors which are activated after the hypoxia that causes the angiogenesis. You know, in case of a hypoxia, these factors get activated and they will form the and they will cause the angiogenesis. So von Hippel-Lindau actually inhibits these factors. If it become mutated, then these factors will become so much activated, they will cause the angiogenesis and they will cause the blood vessel tumors or other kind of tumors, you know. And the classical triad includes the renal cell carcinoma, the pheochromocytoma, and the hemangioblastoma. Okay, pheochromocytoma, RCC, and the hemangioblastoma. You need to know the location of the gene, which is a 3P. P is the long arm of the chromosome. Okay, so long arm of the third chromosome. Then the WT1, okay, which actually causes the Wilms tumor. Okay, also known as a nephroblastoma. Okay, it is derived from the I think the blast cells of the PCT. I'm not sure about it. We will study that later in the later sections also. Okay, but the stem cells or the embryonical cells which forms the kidneys, they become mutated and they will form the tumor in the kids, in the infants. And these are the nephroblastoma. It is due to the WT1. And three type of, I think, three disorders are associated with the WT1. Okay, and they include the Danny-Dash syndrome, the Beckwith-Wiedemann syndrome, and one more, which was, anyone remember? The Beckwith syndrome, the Danny-Dash syndrome, and one more syndrome was there for the WT1 gene. The Vagar syndrome, remember? The Wilms tumor, aniridia, the GI malformations, and this mental retardation. The Vagar syndrome, the Danny-Dash syndrome, and the Beckwith-Wiedemann syndrome you will get in the WT1 mutations. Okay. So yeah, that's on this table about the tumor suppressor genes and the proto-oncogenes. Any doubt in it? Anyone? Any doubt?
No.
Once you encounter every question on the UL on these tables, you will be able to kind of memorize this table very easily. Okay. I know it's hard to memorize, but after encounter the questions, it would be very easy for you to memorize. And one more thing, every tumor that you studied here, okay, every disease that you study here, all of them are the autosomal dominant. Okay, every hereditary disease that you studied here, all of them are the autosomal dominant, and that's why I said every cancer that you will study, every hereditary type of cancer, they are all gonna be the autosomal dominant, right? And you need only one mutation in the proto-oncogenes, but you need the two mutations in the tumor suppressor genes to cause the cancer. Okay, the nuts and two-hit hypothesis. Then certain carcinogens, and you must remember what carcinogen can cause what cancer. Step one will ask you, they will give you a history of certain patient, and they will ask you why the cancer is happening in this patient. What are the risk factors associated with it? So the aflatoxins, which are released by the aspergillus, and you found them in the nuts, okay, and the stored grain. So it is, it is always going to be a case of a farmer who does, who does the farming of the nuts. So he will get the cancer by the aspergillus. And like I already mentioned in the microbiology section while I was talking about the funguses, they releases the aflatoxins, which can cause the hepatocellular carcinomas. Okay. Then comes the alkylating agents, which you give in the chemotherapy, and it is a very sad fact that the chemotherapy which was which was treating one kind of a cancer, it can cause other kind of a cancer also. Okay, so the chemotherapy, they contain the alkylating agents and they can cause the leukemia. So whenever step one gives you a history of a patient who has this hepatocellular carcinoma or the RCC and received the chemotherapy, and after years later he developed the leukemia, so it is not a hereditary cause of the cancer, it is not the P53 mutation, but the fact that the chemotherapy caused him the cancer. Okay, do not confuse it with the T53 or the type of mutations. It's just the result of chemotherapy that is developing the cancers. Then comes the aromatic amines, which is seen in the cigarette smoking. Okay, the cigarette, because all the pathways to which a cigarette moves, once you inhale the cigarette tobacco, it will go to your oral cavity, then it will go to your esophagus, it will go to your GI section, right? Then finally it will go to your kidneys, it will go to your it will go to your urinary bladder, and finally it would be excreted from your cell, from your body, right? So in the bladder, it can cause the transitional cell carcinoma. Okay, in the oropharynx, because this smoke goes through the oropharynx, it can cause the oropharyngeal cancer. Okay, it is goes it will go through your esophagus, so it can cause the squamous cell carcinoma or the adenocarcinoma of the esophagus. Does anyone recognize the location of the esophageal carcinomas, that the squamous cell carcinoma and the adenocarcinoma, the location of these cancers?
Commercial cancer is in the upper part and adenocarcinoma is in the lower part.
Yeah, exactly, upper 2/3 and lower 1/3. Okay, please remember this. So esophageal carcinoma done, and then comes the pancreatic carcinoma. Please remember, the pancreatic carcinoma has a very strong association with the cigarette smoking. Very strong association. So it can lead to the pancreatic adenocarcinoma also. Okay, then smoke can go to your lung, and in the lung it can cause the squamous cell or the small cell carcinoma. Every carcinoma in the lung which starts with name S, the squamous cell or the small cell, it could be caused by the cigarette smoking. Okay, then it can also go through your larynx while going to your lung, and there it can cause a squamous cell carcinoma. Okay, it will go to your bladder, and there it can cause a transitional cell carcinoma. Finally, the cervical cancer can also occur by the smoking. It can cause a squamous cell carcinoma there. Okay, so every pathway, every location to which the smoke can go, it can cause the cancer there. Then comes the arsenic, which is present in the in the herbicides or the metal smelting areas. Okay, so it can cause the angiosarcoma. Very important, arsenic can cause the angiosarcoma most commonly, and very minorly it can cause a lung cancer or squamous. So you can even neglect these two cancers, but the most important thing to know is the angiosarcoma of the liver is caused by the arsenic, and it is a very highly malignant cancer. The metastasis happens very rapidly in case of angiosarcoma. Okay, Then the asbestosis, which you guys already know. Asbestosis in the lung can cause the mesothelioma or the bronchogenic carcinoma, but most commonly it causes the bronchogenic carcinoma. Okay, and one more thing about the mesothelioma, that this mesothelioma can only be caused by the asbestosis. Smoking is not a risk factor for the mesothelioma. It can only be caused by the asbestosis. But asbestosis most commonly causes the bronchogenic carcinoma and secondly the mesothelioma. Then the ethanol, it can damage your liver, it can damage your esophagus. In the esophagus, it can cause a squamous cell carcinoma. In the liver, it can cause the hepatocellular carcinoma. Then the radiations mainly affect your thyroid gland, and in the thyroid gland, it can lead to the papillary thyroid carcinoma. Okay, so papillary thyroid carcinoma can be sporadic by the radiations, or it could be hereditary by the Baraf mutation. Remember, Baraf or Ras? It was Baraf, right? Yeah, it was Baraf. BRAF mutation.
Bra.
Yeah, BRAF mutations. Okay, and yeah, then comes the beryllium, silica, or the nickels, like the occupational lung diseases. You will study that later in the respiratory sections, because there are example of chronic inflammation, and like I told you, every chronic inflammation can lead to the cancer, and they all causes the chronic inflammation, so they all can cause the lung cancer. Then the nitrosamines, which are present in the smoked food or the preserved foods like pickles, they all contain the nitrosamines, and they all can cause the gastric cancer. And they have a very high incidence in the Japan, because in the Japan the people used to eat the the smoked fishes, right? So gastric cancer has a very high incidence in the Japan. So step one will give you a patient from the Japan. He's having the gastric cancer, and they will give you a history of smoking. They will give you a history of Japan, and they will ask you what is the most important risk factor or what is the cause of the patient's cancer. So they will give you the smoking, and they will give you the diet. You need to choose the diet, because this smoked food are much more important than the cigarette smoking for the gastric cancer. Although the cigarette smoking can cause a gastric cancer also, but most importantly, it is caused by the smoked foods. There was a question in the NBME where they have given both of these options, the smoking and the smoked foods, and the answer goes to the smoked food, because it is much more important than the smoking. Then the radones, which is mostly found in the basements, and you need to know that it is the second leading cause of cancer after the smoking. Second leading cause of the lung cancer after the smoking. It is found in the basements. Okay. Then the vinyl chloride, which is generally seen in the plumbers or the shipyard workers. It can cause the liver cancer, the angiosarcoma. So angiosarcoma can be caused by two toxins. One is the arsenic, and second is the vinyl chloride. You will study that later in the GI section of the liver. The cause of angiosarcoma includes the vinyl chloride use or the arsenic use. And again, the non-ionizing radiations like UVB radiation, they can cause the skin cancer, because it is not absorbed by our skin. It will just move superficially on the skin and can cause the skin cancer. Can anyone remember the damage the UVB light caused to your DNA?
Pyrimidine dimers.
Yeah, exactly, the pyrimidine dimers. And what DNA repair thing will repair this?
NER.
Yeah, exactly. Very good. So yeah, that's about the carcinogens. And you need to know that most of the carcinogens, when enters your body, they are in the inactivated form. Okay, and then your cell have this cytochrome P450 monooxygenase, and this cytochrome P450 monooxygenase convert them into the activated form. Okay, and a genetic predisposition or a kind of variance is found in the activity of the cytochrome P450. So those individuals which have a high activity of cytochrome P450 in them, they are very a kind of very much susceptible to these carcinogens. And those who have the very low activity of cytochrome P450, they are kind of very less susceptible to the carcinogens. So it is the cytochrome P450 monooxygenase. Very important to know the name. All of them are the inactivated, but they become activated by this enzyme. Okay. Yeah. So any doubts so far?
No, thank you.
Okay, so I think we should stop here for now, guys. My throat is not supporting me anymore.
Yeah, sure.
Okay, sir.
Okay.
No problem.
Okay. I hope you're able to learn these names very easily now, because it is kind of hard to remember everything on this page, these 2-3 pages, right? But if you remember the pathway, you can easily learn them.
Yes, that's easier like
Thank you
that.
so much.
Thank you so much.
Thank you so much.
Thank you, sir.